Good morning, everyone. We will delay the opening of this wonderful symposium by 5 more minutes. I think many of our speakers are sort of stuck in shuttle mode right now. So just 5 more minutes, enjoy your breakfast and your coffee, and we'll start soon. And we'll get you out on time. All right. All right, well, good morning, everyone. Good morning. Good morning, Dr. Ward. It's wonderful to see everyone here. I know it's a Saturday morning early, it's summer, it's humid, it's all of those things. Thank you for being here. A lot more hopefully will be trickling in, and there are many more online. It's difficult to get that feeling. It's a larger meeting, but it is. Thank you for being here. The person who's supposed to introduce me, Dr. Singhal, is sleeping. We just discovered that right now. He's taking a shower, and he'll be here soon. I promised him I'll make that public news. So I'll introduce myself. My name is Hashem El-Serag. I'm a professor and chair of the Department of Medicine here at Baylor College of Medicine in Houston. I'm co-directing this meeting today. And this meeting has happened through a collaboration between Baylor College of Medicine, where I work, between TEC, which is the Texas Collaborative Center for Hepatocellular Carcinoma, a center funded by the Cancer Prevention Research Institute of Texas, Rice University Baker Institute for Public Policy, where we're sitting here today, and those four entities resulted in today. Apart from welcoming you, I'm going to give you an overview for why we're here today, set the context for the rest of the day, and get us started. So this is the TEC, and I encourage some of you, all of you, to look us up on the website. It's an entity that is funded now 3 years ago by Sept, and the reason to fund it, this is what they want us to do, that's what we proposed, is to reduce hepatocellular carcinoma mortality in Texas by reducing the number of people who develop the cancer or by detecting it early to treat it. So it's focused on prevention and early diagnosis, and they wanted us to make an impact. Our goal is not new discoveries only, but to reduce the mortality. We had several main arms of the mission. One of them is to support and enhance research collaboration among the different researchers. The second is set up the frame to educate healthcare providers and the community. And the third, which touches on today, is engage stakeholders and solicit strategies to improve HCC-related prevention in care and best disseminate those improvements, engage private and public entities in policy considerations. So the last 2-3 bullets is or pertain to today's purpose. To anchor this, some of you who live in Texas know this, others may know that. Texas right now leads the nation in the incidence of hepatocellular carcinoma, or liver cancer, the primary form of liver cancer. So while this map shows that there are several red states in the south and the west coast, Texas is number one. I believe Louisiana and Mississippi compete for second and third place. So that got the attention of Sept. This is the incidence rates of hepatocellular carcinoma in Texas. In this graph, there are 6 lines. The top 3 lines pertain to Texas. The very top line is Texas Latinos. Texas Latinos have 3 times the incidence of HCC as the national average. It's really staggering rates. Some parts, and you can look at the color-coded map of Texas there, the border counties, some of them have incidence rates akin to China, Taiwan, Korea. I mean, the really, really high rates. Why this is a big deal? Because it's a highly fatal cancer. Thank you, Dr. Rich, for sharing this slide. In anyone who gets liver cancer, on average, the mortality is very, very high. So 1 in 5 would survive in 5 years. In Texas, it's even worse. 1 in 6 would survive in 5 years. So we have the highest rate of a highly fatal cancer, and some groups in Texas have rates that are off the charts. Why we're here? Because also hepatocellular carcinoma happens to be quite preventable. We know the risk factors that cause most cases of hepatocellular carcinoma. It's hepatitis C, non-alcoholic fatty liver disease, alcoholic liver disease, hepatitis B. We actually know how to screen for these major risk factors. The discoveries and the tests have been done, and people know what the tests are. We know how to diagnose them, and we can treat them. And in many instances, the treatment are almost miraculous. So Hep C, we can now cure 90% of people with Hep C. We can achieve adequate suppression of the virus in 90% or more of those who have Hep B. Alcohol and NAFLD, there are lower rates of success, but there are algorithms of what to do. How do those risk factors contribute to liver cancer? You're going to hear a detailed talk by Dr. Thrift, but this is a representation. Hepatitis C, while declining because of the treatment and detection, still the major cause of hepatocellular carcinoma in the US and in Texas. Followed by alcoholic liver disease, followed by non-alcoholic fatty liver disease and hepatitis B. So the map of risk factors looks like this. And there are national goals, and you're going to hear our keynote speaker at lunchtime, Dr. Ward, telling us a lot more about elimination plans and goals. So there are national goals to eliminate hepatitis C, and depending on the plan you read, it's either 2020, which passed, and 2030. So people have setting benchmarks that we in Texas, and I'm not spoiling anything here by saying we're way far behind. There's also a global pandemic of obesity. Unfortunately, our state also competes for the top 2 or 3 obese nations or states in the nation. That is highly linked to this entity of non-alcoholic fatty liver disease. And I want to highlight here that 1 in 3 Latinos in Texas have fatty liver disease. 1 in 4 adults in Texas have fatty liver disease. Of those with fatty liver disease, 1 in 5 would develop this entity called NASH, which has more scarring and fibrosis, and that leads to cirrhosis. You'll hear a lot about cirrhosis today because it is the major underlying condition that precedes liver cancer. And the problems, unlike or maybe more than hepatitis C and others, is non-alcoholic fatty liver disease, while common, is highly under-detected. So 20% or so might be even mentioned casually as a diagnosis, much less are counseled regarding their disease, much less are referred, and much, much less undergo real workup and treatment. So hepatocellular carcinoma is a major entity in Texas. We lead the nation. Latinos are mostly affected. It's highly fatal. We know what the risk factors, and we know how to treat them. Our consortium have broken down the steps in the pathway to prevent and early detect hepatocellular carcinoma, and we published this recently, and we kind of know what the steps are. It starts by risk assessment, primary prevention, detection, and there are well-delineated steps under each of these boxes. And then We dreamt up of possible interventions that would underlie this, but we discovered that writing these things on a piece of paper will be just that, on a piece of paper, and you get a nice glossy publication. And we're hoping today will be a start of moving that glossy piece of paper into real action by bringing different stakeholders to advise us, to form a coalition, and to take next steps. So going back to wrap up, today's meeting is integral to the consortium. It touches on those two main points, and we're trying to change policy, or policy changes may be in the works by the end of the day. If you look up how people change policy, there are different things involved. The first one is problem identification, and I think today we'll cover this squarely. We will define what the problem is. We'll give you a flavor of the green part, which is policy analysis. What is there and what is not there? And then we have all the other colors left, which is formulate a strategy, policy development, policy enactment, etc. In the center of this, which hopefully today is the start of it, is the stakeholder engagement and education. So today's meeting format will have a morning speakers. They'll define the disease burden. They'll define the known methods for screening, diagnosis, and the methods for that, determine the important gaps in current practices relevant to Texas as much as possible, describe successful demonstration projects that have already been done to remedy some of these gaps. At lunchtime, we're going to have keynote speakers addressing the global and local hepatitis C elimination efforts, and we'll have also a speaker about the payer's perspective. In the afternoon, we're going to have an hour and a half of a multi-stakeholders meeting discussing a roadmap towards prevention and early diagnosis, identify high-impact policy changes, and discuss next steps. I believe many people who showed up today is the beginning of the coalition. I'm not going to read every line here, but that tells you about the people in this room and online and others who lent their support already to this initiative. So I think the coalition is already forming, and I'm looking for it to solidify throughout the day and afterwards. So my summary, I said it several times, but I think it's important to reiterate. Texas has the highest rates in the nation of HCC. Prevention and early detection are paramount. There's already considerable knowledge about HCC prevention and early diagnosis. There are clear gaps that you're going to hear about in this prevention effort. Many of these gaps are addressable through better implementation of known strategies and tactics. Some gaps may require new solutions like policy changes, and today, hopefully, is a first and an important step in setting up a roadmap with products that may include a white paper, an executive summary, policy changes to pursue, and strategies possibly to pursue those policy changes. So thank you very much. It gives me pleasure to introduce our next speaker, Dr. Aaron Thrift. He is our senior liver epidemiologist here at Baylor. He's an associate professor in the Department of Medicine, and he'll describe liver cirrhosis and hepatocellular carcinoma 101, focusing on disease burden, risk factors, and disparities. Aaron, thank you.
Great, thank you, Hashem. We've tried to sort of reduce the overlap between my talk and his, but he certainly stole my thunder. The intent really of mine is to bang home the same messages. Liver cancer is increasingly common, with high mortality rate. It affects minorities in the US, particularly in Texas, but is highly preventable, and I'll show some data to support those statements. This is why I'm here today on a Saturday instead of being at home rewatching Bluey with my kids. If you haven't seen it, you really should. This figure shows percentage change in mortality rates for various cancer types in the US. If it's red, it means it's increasing. If it's blue, it's decreasing. And as you can see, liver cancer, the majority of which are hepatocellular carcinoma, is one of the only cancer types in the US with increasing mortality rates. Here it's shown at 0.5% per year. If we looked at earlier periods, that rate will be much higher. building on the plot that Dr. El-Serag showed, where Hispanics in Texas have the highest rates for liver cancer in the United States. You can see here that actually incidence rates for hepatocellular carcinoma in the US, in Texas, cluster in certain areas of the state, and particularly along the border region, which obviously have high populations of Latinos. The increasing incidence of liver cancer is driven by what they call a birth cohort effect. So depending on when you're born, you and people born at the same time as you are exposed to certain risk factors, or have a certain risk factor profile that you carry throughout your life. And we know, and there's very convincing evidence, and this plot shows nicely, that the increasing incidence in the US has been primarily driven by a birth cohort effect, where baby boomers in the US were exposed to high rates of hepatitis C virus infection. In the figure you can see, plotted here on the x-axis is year of death, and the y-axis is the death rate per 100,000. You can really see that most of the increase in the mortality rate for liver cancer is among that birth cohort of people born in the peak hepatitis C infection era, so the baby boomer population. But what we're seeing now is perhaps a stabilisation of the incidence rates. If we looked at more recent data for the US, we see that after a sustained period of growth at around 4 to 5% per year, incidence rates for liver cancer have stabilised and may be declining in the US. And if we look at the same phenomenon of this birth cohort effect, so the peak there, the reference group, is that hepatitis C birth cohort, and we see relative to that group, birth cohorts before that had lower incidence rates, and it increased towards that for a peak. But if you look at the most recent birth cohorts, successive birth cohorts now have fairly stable incidence rates. It hasn't returned to that baseline rate of people born in the early 1920s and 30s. So something else is going to sustain the high burden, but we're certainly seeing a stabilisation in rates. Okay, so there are three sort of distinct phases of cancer control, and today I'm sure we'll hear from all three, but my focus is primarily on prevention. So can we identify risk factors in order to prevent someone from developing cancer in the first place? This was touched on earlier, but primarily the main risk factors or the main etiology of liver cancer in the US is alcohol, hepatitis B, hepatitis C, and then NAFLD or NASH, as Dr. El-Serag mentioned. And that sort of risk factor profile does differ globally, but that's the focus of our efforts in the US. I wanted to present now just sort of a fairly theoretical idea of, given that we know what causes liver cancer, what burden of liver cancer is attributed to those, and therefore theoretically could be removed from the population. So we did that through estimating the preventable fraction, which is the proportion by which the incidence rate of the outcome, so liver cancer, in the population would be reduced if the exposures were eliminated. And just a fairly simple example, just to look at the number of cases attributed to obesity. So if obesity didn't cause cancer, and 40% of the population if overweight and obesity didn't cause cancer, and 40% of the population were overweight or obese, you'd expect the distribution of cancer cases would mirror the distribution of overweight in the population. So if you had 100 cancer cases, you'd expect 60 of those in the healthy weight group and 40 of those in the overweight group. However, we know that theoretically that being overweight confers 1.5-fold higher risk of cancer compared to being healthy weight. So what you actually observe is 1.5 times more cancer cases in the overweight group than you would if they had the same risk as the overweight group. So instead, as the healthy weight group. So instead of observing 40 cases in the overweight group, we actually observed 60 cases. And what we want to do is estimate the the proportion of preventable liver cancer cases, which is a number of excess, so in this example it would be the 20 divided by the total number, which is 120. So theoretically, if we removed the overweight from the population, you could prevent almost 17% of cancer cases in that example. So we did this. We did this for Texas based on cancer counts in 2015. To do it, we first of all, we went to the literature to find out what factors are known to be causally related to liver cancer. We need risk estimates, we need prevalence data, and then we can estimate the population attributable fraction. So for liver cancer, looking at places like the International Agency for Research on Cancer and other bodies throughout the world, there is convincing or strong evidence that alcohol consumption, overweight, obesity, tobacco smoking, hepatitis B and hepatitis C infection cause liver cancer. So with that knowledge, we set out to estimate this population attributable fraction. I won't go through it, but essentially it's a product of the proportion of the population exposed times the excess risk in that population. So if we went back to that prior example, if you look on the left-hand side of the slide, so 0.6 times 0, 60% of the population have healthy weight. We know that they don't have excess risk, so it's times 0. 40% are overweight. We know that they have 0.5 higher excess risk for cancer, so we get the same outcome of 17%. So what does it look like for liver cancer in Texas? It's actually highly preventable. Based on these 5 risk factors alone, and here we're talking about eliminating the exposure entirely, but in reality what you're going to do is shift the distribution. For example, you're going to shift the distribution of BMI to the left so that we have less overweight and obese and more healthy weight. But if we did that, we can eliminate almost 2/3 of liver cancer in Texas. That proportion does differ between males and females. We can see it's almost 70% in males, but 50% in females. And the contribution of the various risk factors is different across males and females. And it also differs by race ethnicity. We can actually have a bigger bang for our buck in terms of preventing cancers among the minority populations. So in particular, non-Hispanic blacks who have 2-fold higher incidence of liver cancer compared to non-Hispanic whites. Over 80% of cancers in males could be prevented if we focused on those 5 risk factors. I didn't touch on NAFLD specifically, but we know it's a consequence of obesity and metabolic dysregulation, and Dr. El-Serag mentioned the prevalence here in Texas. It's a global problem. In North America, around 35% of the population have non-alcoholic fatty liver disease. And it confers higher risk for liver cancer. Here, just plotted is the cumulative incidence for liver cancer in controls versus in NAFLD patients versus controls without NAFLD. So what we can see is that there's a clear separation between those two curves. NAFLD confers around 8-fold higher risk of liver cancer compared to the general population. However, the risk conferred by NAFLD is actually lower than what we see in hepatitis C, and it's actually lower than what we see in cured hepatitis C as well. This is a cirrhosis population looking at incidence of liver cancer over time, and we can see patients with non-alcoholic fatty liver disease related cirrhosis have the sort of lowest risk in terms of future risk for liver cancer. Bringing it back to the cohort effect, I mentioned earlier that it's stabilising. We're seeing successive generations with similar risk, but we don't know what's going to happen in the future, especially with that growing population of patients with non-alcoholic fatty liver disease, especially in the growing Latino population in the US. So we have to sit and wait. Or we could work on prevention. So key points in terms of my slides. Liver cancer is highly preventable. We focus on hepatitis C screening and treatment, NAFLD or NASH screening and potentially dietary intervention in those populations. There is a change in risk factor profile that Dr. El-Serag mentioned. So less active viral hepatitis, more obesity, metabolic syndrome, and NAFLD and NASH. There's a change in the risk conferred, as I mentioned, from these risk factors. So we're going from a risk factor, hepatitis C, which is fairly low prevalence with a high relative risk, to a NAFLD, which is very common in the population but confers a lower risk compared to hepatitis C. So what do we need? We need enhanced primary prevention efforts, a focus on risk stratification, and to address the high burden in minority populations in the United States. Thank you.
Thank you. Our moderator now will be Dr. Montelegri. She is the co-director of the Community Outreach Committee and the tech and our implementation guru at Baylor College of Medicine.
Good morning, everyone, and welcome. We're so excited to see everybody here coming together to figure out how we're going to deal with this growing liver cancer problem in our state. So I'm very excited about the session that I'm going to be moderating, which is on advances and gaps in risk and risk assessment and prevention. I would like to introduce our speakers. My colleague and friend, Dr. Sumit Azrani, who is a transplant hepatologist at Baylor University Medical Center at Baylor Scott and White Health. Dr. Azrani, please come up. We also have Dr. Brett Fortune, who is the medical director of liver transplant at Montelegri Health System. So if you please come up and take a seat, we'll have everybody come up here for the session. And then Dr. Barbara Turner, who is a clinical professor of medicine at Gurr Family Center for Health System Science and Innovation at the University of Southern California. So please, you may win the prize for having traveled the farthest. So please come up, we'll take a seat over here. And then Dr. Azrani, we'll start with you. Dr. Azrani is going to tell us about the current state of prevention of liver cancer, at where we are, and what are the gaps in prevention that we can address. So without further ado, Dr. Azrani, thanks.
Thank you, Jane. So I'll talk about, where are we in terms of preventing liver cancer and sort of, highlighting this whole issue of, how do we assess patients, how do we prevent cancer? This is the big message. Yellow is the new red, okay? For all those people who think cardiology is so cool, no, it's all hepatology, okay? So yellow, our patients get jaundiced, okay, so yellow. And red, cardiology. And the thought is that, we've, as a society, paid so much appropriate emphasis to cardiology and heart issues and women and heart disease, but we've sort of forgotten liver disease, which is sort of coming up. And there's so much overlap, and we'll comment on some of that. And I'll go into that. And the three big things, to sort of think about is, again, the same message. It's fatty liver, alcohol, hepatitis C. For liver cancer to develop, for most cases, you have to have cirrhosis, and that's where the liver is getting scarred and not working as well. So the process takes about 20, 30 years of having a hard liver, and then in a subset, you end up with liver cancer. Across the world, 2 million deaths because of liver disease. In the US, about 60 to 80,000 deaths a year. Every year, about 20,000 wait for a transplant, and about 8,000 get a transplant. Liver cancer is up there. And then again, Texas has one of the highest rates of cirrhosis and liver cancer in the country. And we looked at this just in Dallas-Fort Worth. So this is looking across healthcare systems, so not just Baylor Dallas, UT Southwestern, Methodist. And we line up all the 85 hospitals in the Dallas-Fort Worth area, and this is what you see. On the left side is this growth of liver disease across, and this is reflective also in national data. And on the right, what we said is, okay, we talk about heart failure, we talk about COPD, what about liver disease? So if you just look at liver disease as compared to other chronic conditions, and here, liver is the red, is what you're seeing is there's been this dramatic increase in liver-related burden over the last 10, 15 years. So other chronic conditions have done a good job in terms of controlling things, but liver is up there. And the other theme that we've seen is that many of our patients are transitioning into this Medicare population. So it used to be 40s, 50s, and now about 40, 45% of our patients are above the age of 65. So another thing to think about how things have changed. And the cirrhosis patient has a new face. For those here who've been to medical school in the crowd, this is what we were taught, right? Patient comes in and has, is wasting away, has this huge belly full of fluid, and that's what cirrhosis was taught as. But more and more, cirrhosis is becoming like this. It's really hard to say who has cirrhosis, who has not. And this is one of my favorite movies, 5 points if anybody knows what movie it is. Wally, there you go. Okay. 5, 10, 15, good. So this is where liver disease is headed, that it's become fatty liver, and we just are not that good at diagnosing it. One of the big things is, don't lie, everybody in this room drinks alcohol in some form or the other. And if you look in the in the world, 2.4 billion people in the world use alcohol. 2.4 billion in some form or the other. So keep that number in mind. 2.4 billion use alcohol, 24 million have a scarred liver or cirrhosis, 2.4 million have decompensated cirrhosis with the complications set in, and then out of these, about 300,000 deaths, or 200, and this is just because of alcohol. So alcohol, in a way, for every 100 deaths, 1 out of 100 deaths across the world is related to alcohol. Second is fatty liver. And I'll walk you through this. So each of these bars is one single year. And this is looking at, let's say on the left is Europe, Asia, then getting into, in the highlighted box is us, is every single year, this is how fatty liver or obesity has increased. And we, in the high-income West countries, have the highest skyscraper in terms of fatty liver disease. So even obesity and alcohol, again, that's the second thing. And then the third thing is hepatitis C. So this was sort of earlier data. This was before some of the new treatments had been more mainstream for hepatitis C. And what you're seeing on the x-axis is the years, on the y-axis is the number of cases. And we're sort of, as Aaron also highlighted, we're sort of at that peak of, cirrhosis related to hepatitis C, but the burden of liver cancer, continues related to hepatitis C. So despite the treatment, we need to be aware of the risk that continues. And so what's our current state in HCC prevention? When we think about the continuum of how patients progress through this, and you can put in any chronic disease here, right? You have chronic liver disease, then you have cirrhosis, where the liver gets scarred. Then you have decompensation, whether you run into trouble because of your liver. You can get liver cancer. And then your option sort of is either you linger on, or it's transplant and death. And the big thing here is, how do we, in this group here, look at those three things that I've highlighted? One is, how do we get patients to be recognized early? How do we treat early? How do we predict progression so we catch patients at the chronic liver disease state and not let them go through this whole pathway? And it's repeat. I came up with this mnemonic, so please appreciate it. Okay, so there's recognize early, which is, this is what we do, right? We visits, labs, imaging. We educate, community, patient, provider. We try to predict, visits, labs, imaging, and then we treat, medicines, procedures, transplant. So that's what our paradigm is, right? If we really boil down to it, what do? We just repeat this cycle. And what does prevention look like for all these 3 different conditions that I talked about? Ideally, what would happen is we would, for hepatitis C, have universal testing at primary care. Right now, everybody above the age of 18 should be screened for Hep C. And then, so Jeff runs a network of, 7 clinics in Dallas. Does everybody get access to it? I don't know. Or Craig, who's also in the audience, who's heading HTPN for Dallas. Does everybody get to this? I don't know. So step 1 is universal access, testing at primary care. 2 is early access to therapy. 3 is you treat them. You vaccinate for other conditions such as hepatitis B, and then you surveillance the high-risk patients and increase liver cancer awareness. Simple paradigm. What does prevention look like in the ideal world for alcohol, right? Alcohol, you again screen at the primary care level. use tools such as audit. We somehow link patients in, again, in this ideal world, to mental health and other support. And then you provide access to specialty care, if needed, for chronic condition management, and have some kind of structure to surveillance for liver cancer. And what about in fatty liver? The issue here is that the prevalence of fatty liver is so high. So we may see 100 fatty liver patients. Not everybody will progress down that path of badness. You probably have a few high-risk patients, but how do we identify those high-risk patients and then escalate care for them? And that's something that Brett Fortune is going to talk about in a little bit. Because even for our fatty liver patients, just to again reiterate this message, is it's not mentioned as a possible diagnosis. So recently, just we looked at our data of how many patients in the Baylor healthcare system has fatty liver, and we came up with a number. But I thought about it, how often do we code for fatty liver? Oftentimes we say elevated liver enzymes or something else, abnormal imaging. So the burden is probably not reported as much. So 1 out of 5 patients who really has fatty liver really gets diagnosed with that. 15% get counseled because we just don't have the tools. And how do we get change to happen, right? Third thing is for appropriate patients, maybe 1 out of 10 gets referred. And in terms of investigation, how often do people get liver biopsies to figure out, how sick they are? And so prevention in an ideal world for fatty liver does become more involved, right? You have, on one hand, you have the nutrition classes, the weight loss therapies, you have chronic disease management. How do we get patients involved for novel therapeutics, exercise regimen, linkage to care, community education? So again, a lot needs to be done for a population that is really going to explode. So where are the gaps in HCC prevention? I think there are 3 big categories. One is underdiagnosis of main risk factors. How often do we really screen for alcohol? We talk about it, maybe in specialty clinic, but do we do it regularly? 2 is education at different levels. And 3 is linkage and access to therapy. Issues. We don't systematically predict high risk. Okay, question number 2. Which ad is this commercial? Anybody know? Yeah, Mac versus PC. Okay. So we don't systematically predict risk. So if you have 2 patients with liver disease in your office, primary care, specialty care, doesn't matter. We really don't have good tools to figure out who's the one that's going to run into trouble. We have this paradigm for other cancers, right? For colonoscopy, we think of colon cancer, we think about colonoscopy. We have people filming their colonoscopies, right? Just recently, last week. For breast cancer, we think of mammograms. For diabetes, we think of A1C. What is the piece for liver disease or liver cancer? We really don't have anything. And we'll highlight some of the tools today, which may or may not be the answer, but at least it'll get us in the right direction. Because at the end of the day is how do we find out who are the people that we really need to worry about? 2, besides early sort of identification of the high-risk patient, is lack of awareness or education at the patient, physician, and public level. Here are a couple of the handouts that we've created. One is one with tech. And how does one sort of disseminate this kind of information, and is it even useful? On the right is some of the materials that we've created for our clinic in Dallas, in English and Spanish. We partnered with some other institutions to develop this. We've added videos. But how do we sort of, get it down to the population that really needs it, and not just educate the patient, the public, but also the physicians taking care of our patients? And 3, the linkage to care, which is lacking. PCP and specialist access, proximity to large centers. Here in Dallas, Fort Worth, you can get care. But what about in Waxahachie, Corsicana, Ennis? How do we get out there in our communities? 2 is, again, on that point, how do we get to our disadvantaged populations, our minorities, low income, rural? And Dr. Rich is going to talk a little bit about that. And how do we really leverage our integrated healthcare systems to make impactful change? And how do we come up with care pathways that we can use across Texas? And then finally, access to therapy and resources are spotty. This is, everybody's wish list. Everybody with their, disease of choice will ask for similar kinds of things. But that's what we need. We need sort of some concerted effort to really prevent this progression of disease. And I'll bring it down to economics, and this is the last slide. Okay, so I talked to you about the paradigm, going from chronic liver disease to transplant to death. If we really think in terms of numbers, right, if we can invest right now at the chronic liver disease on education, lifestyle modification, nutrition, 10,000. Again, this is my ballpark number. Once they get to the scarred liver stage, this is what it's costing our system, right? So we have patients who come in every 6 months, get their labs, imagings, medications. That's about 60,000 a year. Once they run into trouble, then they get into the cycle of hospitalizations. 3 to 4 hospitalizations per patient, cost about 30,000 per hospitalization. That's 120,000 right there. Then our patients get procedures and medications at that level. That's another 100,000. If we get them to transplant, yay, okay. That's, at our center, maybe 125 patients. That's about 200,000 plus the repeated hospitalizations after that. And then finally, again, besides the human cost, if we just think in terms of economics, our patients, if they're dying in their 40s, 50s, 60s, right? This is not cardiology where it's 70s, 80s. And this is sort of premature death and lost productivity. So again, even in terms of economics, it makes sense to start now. And I think this kind of approach to go across healthcare systems, across Texas, is really needed. So I'll stop there. Yellow is the new red. And thank you for listening. And then I'll introduce Brett Fortune just briefly. So Brett Fortune is a good friend. He's trained in Colorado. He's trained at Yale. He was at Columbia, and now is putting his stamp at Montefiore as the medical director of liver transplant. His passion is taking care of disadvantaged populations. But the second thing is his interest is how do we leverage all this EMR, electronic medical records that we have to make impactful change.
Great. Thank you so much. So just the forward button here. Good morning, everyone. Thank you so much for having me. Thank you for the organizers for inviting me to this amazing effort, and hope to take a lot of this information to take it back to New York, where we definitely have some vulnerable populations that are also dealing with substantially above average risk of advanced liver disease and cancer. So let me get to, oh, this is not my talk. Is it out of order? This is your second talk. Is there an AV person? Sorry, it's put back to back. Oh, here we go. Thank you. There we go. Oh, you had it there. Just a quick pause. Anyway, while they're putting it up, I'm very excited to kind of go over more of the conceptual framework that I think is really necessary to address. In medicine, we're one of the few fields that really has been slow to utilize technology, and I feel it is really where we have to go, especially when you're talking about the kind of population size, particularly in fatty liver disease, and the really lack of care support, because obviously a hepatologist can't see every one of these patients. Our clinics are inundated with a lot of these patients, and yet we cannot meet the means. So really trying to figure out population science and using technology to better empower primary care doctors as well as patients is really the next step. So anyway, as Dr. Zrani kindly mentioned, I'm the medical director of liver transplant at Montefiore, which is located in the Bronx, New York. And we're going to talk about kind of using technology to better create risk assessments as a tool for prevention, particularly in advanced liver disease and cancer. These are my disclosures and no conflicts. So what I hope to do, or hope the group in general at the end of today will be able to talk about what do we know now, which has already gotten a great start, and hopefully by the end of today, we'll even have more knowledge. And so some things that you may see commonly described in every of the talks is right now, healthcare systems poorly screen for chronic liver disease, period, even among those with greatest risk. And as Dr. Zrani showed on that illustrative slide of Pixar movies, it helps show that it's getting harder and harder to identify these patients because they appear like the general population. obviously, I think it goes without saying that detection of earlier disease is better than late. It's not only better from a more therapeutic response, but also from a cost-saving standpoint. And in this case, we're talking about trying to prevent before they develop early fibrosis or scarring, and obviously development of decompensation, liver disease, or cancer. And then obviously trying to standardize this so that implementation of processes and policies can be applied anywhere or wherever, whether it's urban, large center, small center, and that would be the ideal setting. But the question is it obtainable? And if so, how do we do that? And maybe we'll be able to highlight some of that by the end of today. One of the things that I think, and I'm definitely investing in, is I believe technology can help us, as it has helped in many of our businesses and medicine over the years. And one of the benefits since healthcare has been kind of switched over to an electronic health record is the ability to use big data and machine learning and artificial intelligence to help the human aspect. And so how do we identify these patients? How do we properly risk stratify them? And then, as I mentioned, and it was kind of referenced earlier, is how do we interact with physicians? Because again, hepatologists cannot take this burden completely by themselves. It's impossible. Just like gastroenterologists can't do every colonoscopy on an age 45 or above person. And so we have to empower our primary care force. We have to empower our patients to take recognition and to really get involved in their care. And how do we link them to that care? As pointed out, there are many determinants of health that really reduce your linkage to care. And then also making sure that there's response feedback, because it's one thing if it's a one-way street, but if you're not hearing how things are going, you're really not going to make any improvements in the future. And then lastly, to move forward and turn this into reality, we really have to have partnerships such as what is happening today and implementation science so that we make sure, again, that we're doing the proper feedback loop to see if things are working or what are not. So as you saw earlier, Dr. Serrani's slide, why is disease screening important? As you can see here, all these things are here, but the point is, as he mentioned, that we do not have a proper screening tool for advanced liver disease or cancer. So the question is, can technology help us to create some screening tools, even to at least highlight those at greatest risk for developing chronic liver disease and thus liver cancer? And so looking at his paradigm natural history of liver disease, obviously we would like to identify those patients earlier in the process, not only for outcomes, but also cost. But as opposed to his repeat acronym, we do want to identify these patients early before they develop problems. We want to risk stratify them. We want to get that linkage to care. And then we want the feedback, because again, doing everything one way and not having any feedback does not tell you if it's working. And so it's really important to put that in when you're building these systems. So identification using technology, there can be developed algorithms of using both diagnostic codes, disease groupers, some specifics depending on your electronic health record platform that to help capture these patients with pretty high accuracy. And a lot of my colleagues throughout the country and world have really worked on validating these codes with beta testing and showing very high sensitivity specificity with high accuracy. And so we're learning with the big data of how to identify patients with early alcohol use disorder or early alcohol liver disease. More than just having abnormal liver tests, but also looking at patient-reported outcomes. Every one of these patients has a social history. We're improving our access with the portal, where we actually can use questionnaire surveys. How much are you drinking? Because sometimes patients feel more comfortable answering those questions at home as opposed in the waiting room or in front of the doctor. And so getting more honed in and targeting these patients sooner, using those discrete data can be more helpful of really identifying them quickly and having intervention. And the same can be said for fatty liver disease, not only looking at their metabolic profiles, which are commonly tested in almost every patient, as well as BMI, et cetera. So again, other ways to really capture these patients. And then viral hepatitis, both B and C, whether it's positive serology testing or the birth cohort, et cetera. So what do we do from there if we can identify them? Well, we can risk assess, and there's actually been a lot of literature really looking at non-invasive, simple laboratory-based tests to help with risk stratification to detect advanced fibrosis, which again is the main proponent that leads to decompensated liver disease and cancer. And so how can we simply use, sometimes simplest best, and how do we use this simple risk stratification to help take those patients that you have identified as having liver disease potentially, and then risk stratifying them into certain categories so that you can know different interventions may be applied. And so, for example, the FIB4, which is the 4 components of fibrosis, has been a commonly validated test for the last almost 20 years now of looking at just simply the patient's age, an AST and ALT, which are commonly obtained labs for liver function, and platelet count, which is actually the least commonly tested. But putting that into a score, you can simply be able to risk stratify patients based on validated cutoffs per their liver disease etiology. And you can actually, without doing anything further, can actually accurately detect whether or not they have advanced liver disease or the development of advanced liver disease in the near future. And so by knowing that, when you capture the audience here and actually identify these patients with alcohol, fatty liver, and viral hepatitis, you can then use these risk scores, whether it's FIB4, looking at positive serologies, and the Audit C, which is literally a 3 questionnaire for alcohol use disorder detection, which can easily be done over a portal. And then you can really be able to create risk-specific, disease-specific care pathways and risk stratify on both low risk, high risk, and if you want a third category, intermediate risk. And so that's where you kind of initiate both empowerment, recognition, tell your primary care providers, your patients that, hey, we've identified you as potentially high risk for chronic liver disease, you need to follow up. And with that, how do we develop that care coordination? It was mentioned earlier, it takes a village to manage chronic liver disease. And that's important, and part of a chronic disease management model is to include the patients, their communities, and their primary sector, both PCPs, advanced practice providers. It really can't be where healthcare is kind of turned into this very specialty-heavy delivery system. We have to flip it back to the primary care pre-prevention level. And so notifying them, hey, we've detected that you might be at risk for advanced liver disease. We can actually message them through the provider, through the portal, through their providers, and create actually validated decision pathways that can be very helpful that don't require a hepatology consult. So with that, as I mentioned, notification of the provider, hey, we detected your patient might have liver disease. And we could do this through the entire health system and message the patient, hey, we just wanted to let you know we detected this. These are the things we would suggest. Obviously, technology still has its own implicit biases and some disparities, which will continue. But I could tell you, as every American almost has an iPhone or some type of smartphone, technology can reach everyone, including rural areas or other vulnerable populations. So creating both best practice advisories, other portal messages, more surveys, developing both low and high risk stratifications, such as specific clinical decision pathways that for those low-risk patients, continuing screening intervals that might be more frequent, or having further follow-up with patient-reported outcomes to get more information through the portal, reassess based on a set frequency so they're not forgotten or lost to follow-up. And then for those that are high risk, we would have more intensive, more further risk stratification by using non-invasive imaging. So getting your ultrasounds, which we're trying to avoid on every single patient because you could obviously state that's probably not an adequate use of resources, as well as moving forward to some other technologies such as elastography to help further risk stratify those patients that are identified as high risk. And then for those with the highest risk, that's where you would then refer to your specialists or hepatologists and go forward with further therapies in the future, including both, but counseling for alcohol cessation is really general. Metabolic health and obesity management is general. That is not a hepatology practice. That is an everybody practice. And so we really have to get that empowerment and help educate the community, the patients, and all the healthcare system. So these are just some examples that I took. I work on a steering committee with one of the electronic medical record platforms, Epic, which is one of the larger ones. And there are ways to create risk identification based on certain parameters, such as for early detection of sepsis in admitted patients, which we know earlier detection and early initiation of antibiotics can actually save lives in just a matter of minutes, not even days. In addition, reminders of standard care practices. But what's really cool and something that's been underutilized that I think us as a community can further advance is there are actually these clinical decision pathways that are built in. They're embedded technology tools to help tell patients and doctors what to do if we detect that they have advanced liver disease. And using, whether it's FIB4 or whatever risk stratification you want to use, this is embedded in the electronic medical records. These are recommendations of what we would do next. It's kind of your own virtual consult so that you can help get these patients care without having to be the only 10% that actually make it to the specialists. So you lose that 90%. So you can tackle them on the front line. In addition, you can prompt order sets that can go ahead and risk stratify and all those further things. So you can do all this workup before they even make it to the specialists. So these are things that need to be discussed and built in each institution, but it can be done, and it can be very successful. Finally, it's really important when you talk about implementation science about response feedback. You cannot just do something and never follow up to see if it worked or not. So creating kind of dashboards to track how you're doing. How are you doing with adherence? How are you doing with outcomes? Those kind of things are really important to build when you do these endeavors. And it's luckily these platforms all have the analytical capabilities of doing so internally. And so working with your IT groups or other platforms dependent, you can really develop a lot of these great dashboards and follow kind of the act, plan, study, do cycle, and really optimizing with ongoing feedback and improved performance. And a perfect example is the Cirrhosis and Cancer Screening Dashboard of the VA, which has made a lot of progress and really have almost helped create basically a report card of how each VA is doing in the management of their advanced liver disease and cancer. So, can we make it a reality? We need partnership, which I really applaud this consortium, this collaboration, and I really want to try to figure out how to replicate this in the state of New York. We need to take all the stakeholders and create an overarching objective or goal and form work groups that we can tackle this in a synchronized, coordinated fashion. We need to develop a standardized approach. You can't, if everyone's doing something different, it's hard to implement it. So you need to develop a consensus pathway of how to do that, both in the detection of advanced liver disease as well as screening. You want to make it cost effective, high yield. You can't make it super expensive. You can't make it super unavailable. You know, we can't use MRI-based technology. We need lab-based technology. And we need ongoing assessment of how we're doing. We need to develop, as part of the plan, yearly or every other year, reassessment. How are we doing? How are the dashboards looking? How are we making a difference, as opposed to waiting to your public health statistics to tell you? And so really, you got to involve your policy people, which we're excited to have you here today. Your platform personnel. I can tell you, for example, Epic is extremely interested in really working with the hepatologists, gastroenterologists, and other specialties to enhance the utilization and optimization, because I know a lot of doctors really hate the platforms, but you can make it smarter and be more effective. Topic experts, patients, and providers, I think, is a key to get their feedback. What are their barriers to getting the proper help and education? We need to get a response from them, and obviously the healthcare systems themselves. So there is a future, and obviously what's really exciting is there are a lot of third parties and other companies that are looking at machine learning. You know, obviously the human can only do so much, but if you can take that big data and create validated algorithms, there could be really some exciting enhanced algorithms that are even more accurate than, for example, FIB4. Artificial intelligence is obviously taking what we learn and to test it further. Now, keep in mind, these have limitations and, again, need to be reevaluated to make sure that they're accurate and not missing the big picture. The other thing is taking patient data. We can actually merge all patient-specific data into their own record and then merge that. So, for example, we can follow their weights. We can follow their sleep patterns. We can follow, obviously this gets a little big brother, so you have to have a line. But the point is that you can take all this discrete data and really convert it into some very accurate algorithms. And then obviously, as I mentioned, I think it's really important to account patient-reported outcomes. We know that in chronic liver disease, patient-reported outcomes are independent predictors of survival, and it's very important henceforth with our prospective science to include patient-reported outcomes as part of that pathway. And so I call it health intelligence. The smarter we get, the better we will do in healthcare, and so it's really how we have to, as a group, really take this on as opposed to being resistant to it. So obviously there are a lot of strengths and weaknesses with electronic health record. The majority of health systems are now on the platform because of basically moving laws and stuff. And now there's over nearly 350 million patients. Almost every American has some kind of electronic health record. So there's endless opportunities to really utilize this data and really enhance our care delivery for these patients, regardless of where they live, regardless of what language they speak, regardless of what access they have. And so there are analytical capabilities. I mentioned some of the platforms here that can create dashboards, analytical reports, registries, et cetera. And there's a lot of opportunity to not only do this from the science side, but also the quality improvement side. And so to summarize, I believe technology can help us. I believe that we know that chronic liver disease and liver cancer are highly prevalent in Texas and really around the country, and there is a major need to improve this screen effort. I believe that if we really own technology and work with our partners, as opposed to just following what they provide us, we really can develop very highly intelligent algorithms to identify patients and really be able to perfect our ability for early detection and to be able to empower patients and primary care providers with the ability to care for themselves before they make it to the specialists. With that, accurate risk assessments so that each care pathway is risk-based with high yield and low cost, and then effective notification, as we mentioned, and then transparent, easily tractable care pathways in order to really enhance your leakage of care and proper implementation with response feedback. And with that, I really think we can help start to close the gaps in liver disease. Thank you.
As someone in public health and population health, I just could not stop smiling at everything that you just said. I really love how hepatologists in this room are really kind of thinking about primary care and communities. And with that, we'll have Dr. Turner, who is going to talk specifically about primary care settings and community health settings, where this is really, like Dr. Fortune was just saying, really this needs to happen. We can no longer have specialists be the ones who are responsible for the care for liver disease. So thank you so much for your coming. So Dr. Turner comes from Southern California, where she's a clinical professor of medicine for the Gare Family Center for Health System Sciences. And as I said, talking about community and primary care settings. Thank you.
Well, I think you've done a brilliant job of teeing up these lectures, because I feel that we really are very complementary in our vantage points. Mine is from primary care. I'm a practicing internist, health systems scientist. And I was here for 8 years. How do I make sure of this? Yeah. But I got to say that in Texas for 8 years, it's nice to be back. I don't really have important disclosures. I got to say I've worked with Dr. Singhal over there on my research while I was at UT Health San Antonio. So I'm really going to talk to you about implementing this, and it's not going to be an easy story. The vantage point I have is from a project that was funded over 6 or 7 years to implement HCV screening. It was a time we were focusing on baby boomers, focusing on treating them, and our concentration was in primary care practices throughout South Texas. You can see here in the orange, that's the location of the practices, and Bexar County and Dallas are in blue where we coordinated this. But They were 5 federally qualified health centers. I got to tell you, it's the real world, and it's not the epic world, unfortunately. But we gained a lot of insights from how we serve Medicaid and uninsured patients. It was launched actually in 2014 to 16 in these practices, and honestly, at baseline, no HCV screening was going on, zippo. And this was funded, fortunately, by CPRIT. We were one of the first groups to really get CPRIT, along with Dr. El-Serag, to realize how threatening liver cancer was. So this is actually data from the University of Washington. I just found it's like over 200,000 people in Texas still have chronic hepatitis C. We've got a big problem here. We've already heard about liver cancer, but I want you to focus on the red concentration down in South Texas. That's where we were working, way higher than anywhere else in the country, to be honest. But of course, we've heard the good news. We do have good news if we can only figure this out. You already know about South Texas, the world doesn't, but I gave this talk for federal agencies, and so I wanted to remind them it's mostly Latinx and very low income compared to even the rest of Texas. And so the challenge is, and we've heard about this, is that chronic HCV is a disease of low-income Americans, folks, and so that's another big barrier. I am an implementation scientist. I like using frameworks, so we use the RE-AIM framework to evaluate our study. Are we reaching the population? Is it effective? Are the people who are supposed to be implementing the project really doing it, adopting it? And is it being adopted or implemented with fidelity? And then maintenance is something we really couldn't address very well, but we're going to talk about today. This isn't repeat, but it's the same idea where we're focusing on screening. Now, we've talked a lot about the IT system, and I'll just mention the EMRs in these federally qualified health centers are bottom feeders. Many of them you cannot even modify. You can't use them to monitor patients. You can't use them to identify patients. And we had to lean on the staff to find patients who were eligible. Now, because they just didn't get support for that. And we tried to work with the systems, and they couldn't modify them. So we have other solutions I'll tell you about later to help people know about screening, to minimize the burden of screening with reflex testing, and we made it through funding free for the uninsured. If you tell uninsured people they have to spend $10 on screening for hepatitis C, they'll say no thank you. So it's really important that we solve those problems. And then we did make a registry. Actually, we used the LabCorp and Quest data to find out who got tested because that was our workaround. I'll tell you about a mobile app we made. We did a lot of education. We already talked about that. I'll mention it. Protocols, I agree with you, are super important. And again, testing was free for the uninsured, including ultrasounds. We had to get deals with various radiology groups to make it affordable. I think we have a neat model in the office hours I'll tell you a little bit about. I know Echo is out there everywhere, but this is like low-tech Echo. It's a holistic care plan that involves, these are very complicated patients, so you really have to not just look at the liver. And then care navigation I'll mention. And finally, I just want to say a little bit, and I don't know if I have a pointer here, but prescription assistance programs from the drug companies. I know they like to make money, but they are at least willing to give the medication for free to people who don't have resources. And we took advantage of that with a cure. And the liver ultrasound is off our radar. I think it's a big problem, and I just want to mention that because I won't be addressing it. So we heard you need to listen to the community. That is so true. You have to go out and talk to people. So we had focus groups, meetings with clinicians, with patients to try to figure out how do we solve this and how do we help them. And we developed a website which has a lot of resources on it, or at least had it. It's called stophepatitisc.com, and it had resources for all levels, including clinicians, the community, and hopefully aiming for stakeholders, for people who are going to be funding so they understand what we need to do. Bilingual, low literacy. Challenge to sustainability, funding to keep it up. Community outreach materials. We developed bilingual, attractive materials to hand out at rodeos, at community fairs, and in our clinics. So people really understood more about the disease. We actually have them on alcohol. I got to tell you, I think that's a big focus. Challenge to sustainability, funding for active community outreach. We made testimonials. We got people who were cured of hepatitis C to talk about their stories, because it's not straightforward. And there were a lot of barriers that they had to overcome, and wanted other people to see it was possible to actually cure this disease. We made posters. Now, this is because of this challenge. Patients had no clue, they still have no clue, that they need to be screened for hepatitis C. And the PCP and the team had zero time to explain it. So you don't consent somebody. You say, here, posters, hepatitis C, need to be tested. And nobody turned us down. Everybody said, oh, okay. So it's important to have the information out there so the team doesn't have to bother with that. Education for professionals. We went to all of these practices and gave them individual training programs. We gave them CME for it. We gave them lunch. We tried to make it incentivized. Alcohol, I've got to say at the bottom here, is a lecture that I give in New York, too, because it is so linked for this population, and it is so important that we not ignore it. So we have a 3-part series on alcohol and HCV, but it's also just about alcohol screening and management 101. Challenge to sustainability, funding to continue it. This is cool. The mobile app we made is a very cheap little tablet because we did focus groups with patients, and we found that they had no idea once they were found to have chronic hepatitis C what it was, what should they do about it. So we had an app that we created that had teach back, so we gave them some slides and we said, did you get this? And then the care navigator or the team could just build on that. They didn't have to go through a whole la-di-da about the disease or what needed to be done. It really is that you have to address the stigma. This is not a disease that doesn't carry a problem with it. When you say you have hepatitis C, they say, oh my God, injection drug use, et cetera, and many people need to understand that it's not linked to bad behaviors or even suspect behaviors. The care manager was super important. I have to say, as a primary care physician who's practicing now in an environment where I really don't have care managers, it's really tough because it's all a lot on me. And here you can see at these practices, we were able to fund, depending on the amount of money, various people to help navigate and help these patients through the whole gauntlet of the care continuum. And I'm not going to go through all of this, but you get an idea just scanning how many things needed to be addressed. And this didn't require an MD to do this. Challenge to sustainability, payment for these people. And integration into the practice. When it was somebody that we hired and put in the practice, it was hard to get them to be part of the flow and to have people in the practice really consider them appropriately to utilize their skills. This is kind of cool. So our clinicians, when we went out and talked to them, said, I don't have time to do an echo hour, whatever, every other week. And so we said, okay, we'll get a hepatologist, a wonderful guy at UT Health in San Antonio, to have lunch every other week, and we'll set up office hours with him. And so we had a very protocolized, I'm not going to show you, form with the FIB4 and other data to review with the hepatologist. Only took 10 to 15 minutes. And there was some teaching going on at the same time on top of our lectures. And so we came up with what's the drug to use? What are the problems with this patient? What else to manage? All in that period of time. The care manager was listening and could help operationalize it. There are lots of challenges to sustainability here. How do you pay for a specialist time? How do you incentivize the PCPs to do that at lunchtime? Or even then take on the next steps of management. Payment for the tests of the uninsured, I've already mentioned. Here in Texas, it's a bigger problem than where I come from in California, but it's still an issue. And then the really saddest part was when people had liver cancer, because we had a lot of trouble figuring out for the uninsured how to manage that disease. And sometimes it was like, we can't do much for you. So effectiveness, was this useful? Did we get anything done? These are a lot of the measures that we used in this project, having to do with each one of the re-aim goals that we proceeded with. And I have to tell you that the outcomes that we measure in terms of treatment have to do with the uninsured, because that's the group that we could really control. So overall, this project screened 27,000 individuals in South Texas. We screened about half of them. Remember, we started from 0. And the demographics are really quite typical of South Texas. There were 2/3 were uninsured. And we found that 5% were testing positive for HCV, anti-HCV. And then we were able to get about 3/4 of them tested for RNA, which is another one of the problems when the reflex testing wasn't available. And then we found that about 350 had chronic HCV. Now, I have these 2 columns, just taking examples of the best performing clinic and the worst performing clinic. And although the worst performing clinic actually found more patients, you can see at the top, they only tested 20% of their population. They obviously were picking out the people that were high risk and tested them, which is fine if you think you're getting everybody you need to get. The best performance clinic tested about 70% of the patients, and they found a lower prevalence, but that's because they were doing everybody. And we were able to really manage, I think, a lot of the patients that should have been in most of the practices when we had all the pieces of the puzzle. And we can talk later about what pieces were missing in the worst performing clinic. By the way, this was all published in an Annals of Internal Medicine paper that we had with a qualitative assessment of what went right and what went wrong. But places that don't have somebody who cares a lot, a champion, we really couldn't engage them. If they didn't have as much staff support, an LVN is awesome for this because they can manage clinical issues as well as care navigation, but they cost money. PCPs care about something else, and we can talk about this later. HCV is one of many priorities, and we have to figure out how to put it on their to-do list because there isn't an incentive for this right now. And then the low-quality EMR is really a problem. The Care Cascade, I think, was already mentioned, but that this is an issue, and you can see right here how it plays out, where you can't get everybody, all of those lab tests, the ultrasound done, couldn't get everybody to get that done. These are all uninsured, by the way, I have it highlighted. Getting that teleconsultation scheduled was kind of a pain, but we managed for about 145, and then we dropped down. There was a problem between the consultation and treatment recommended because people had major health issues that needed to be addressed first. So that would delay us going out and trying to initiate treatment. Once we did get the drugs from the PCPAP program, we pretty much were able to keep them in care. But this is a care cascade that's repeated all over the country as a challenge. So I have in highlight here things that really are big challenges to sustainability. Can't figure out how to fix that EMR in very low supported federally qualified health centers. Can't pay for reflex testing. We can't even get the testing for the uninsured. We did make a registry, but we had to have special deals with the lab companies to figure that out. How do you fund care navigation, PCP training? How do you fund these teleconference office hours? I really think ECHO's terrific, but you have to be super dedicated as a PCP to do that. And then how do you address all the other things that are going on? These people, we published a paper, and I, that in the Latino population, you know, alcohol is a big player. And you can treat the HCV, but you still got that problem going on. And obesity. So it is kind of silly to treat just hepatitis C and think, oh, I've cured this patient. And then this liver ultrasound wasn't even on our radar. Policy changes, this is my last slide. I think we have to continue to go out into the community to get them to understand this threat. I think they all get breast cancer and to some extent colon cancer, but we haven't really engaged them enough on liver cancer. We haven't covered care, especially here in this state, for a lot of people. And we need to get that EMR to work, and we have to help those practices get the EMR that works. It's so difficult to be in a place that doesn't have Epic, I've got to tell you, because I'm practicing in a place that doesn't have Epic. And National Quality of Care metric. This I'm so annoyed about, that NQF, the National Quality Fund, has not got this on their radar to pay primary care practices for doing screening, let alone care. So why would I bother when I get paid for A1Cs and mammograms and colon cancer screening? And then I think we have to, this is sort of out there, but an idea of episode of care payment. They do that for hip replacements, et cetera, but I think we have to think about value-based care where we get, you know, once you find, well, if you screen and find somebody with chronic HCV, bing, you know, your compensation goes up, it covers the care management, it covers all of those visits, and I get an incentive to want to do this, but right now it lacks. So I just want to really say thanks to CPRIT. In LA, I miss CPRIT, and other funders have really been very important to this project. And we had a fabulous team. One of them is here, but lots of people made this work, and I want to say thank you.
Wonderful. Please, how are we doing questions? Do we have microphones? Okay, please come up if you have questions. I really appreciated, Dr. Turner, your last presentation following Dr. Fortune's, because I think what you bring up is that unless we design these things for equity and with equity in mind, we're going to essentially, you know, make the gap even more profound. And I just wondered if you, doing the thinking that you're doing and then having sort of the real world experience of what this actually looks like in FQ8Cs and in many of the care settings that see the patients, you know, how do we make sure that everything we do keeps equity sort of at the forefront? Oh, sorry, that's a big question.
Yeah.
Any thoughts?
So you want me to figure out how to solve lack of insurance and lack of health care?
Yes, please.
Okay. All
And
right.
bad EMRs and all that other stuff.
Yes, I think Dr. Turner pointed out nicely that there are clearly some disparities that are necessary to address, which obviously applies to linkage to care and quality of care. And I think that is the whole purpose of this effort, is to help work on emphasizing with policy and coverage to be able to help those that are vulnerable to these gaps so that we can address. So I'll just leave it broad. Yeah, thank you.
Well, I think our audience we want them to participate. So any questions now from the audience?
Hi. So I have a comment and a question for Dr. Turner. So, you know, I stood up there and gave my 10,000-foot view on, you know, liver cancer is high, as a high burden in the minority population. We can prevent it. It's very easy. Look at the burden we can prevent. And I think you brought us all back down to earth with sort of the realities of addressing liver cancer in that population. Just in the setting where you were funded, what does that look like now that you have moved and perhaps the funding has ceased? Just wonder what it's like in that setting now.
I don't know if this is on. It didn't end when I left. It kept going with CPRIT funding. To be honest, it may be sunsetting soon. You know, that makes me really unhappy because CPRIT is like a godmother sprinkling fairy dust around where the real world will not allow us to do this. You know, and I feel that the feds have failed, or at least I know that gastroenterology groups and hepatologists have gone to NQF to make this at least some kind of incentivized thing. But you know, down in South Texas, they have a horrific problem with diabetes. And the guy said, you know, can you help us because we have people coming in already with renal failure from diabetes. And so it's just an issue of priorities. And when you said it's easily addressed, I have to say obesity really is it easily addressed, because in my world, it isn't. And I think that we have really a wave of challenges coming on us. And you point out the issues, and then the last thing I gotta say is I'm a dinosaur. I'm a primary care internist. Do you know how many medical students are going into this as opposed to hospital medicine? So you think of this as being a resource in this nation, but it is a diminishing resource. And I think unless we deal with that pipeline, we also have a big problem.
So we've heard so many great talks, and you're going to hear summaries throughout the day, because the hope is sort of to move despite what looks like it's clutter and it's unsolvable. I think we heard beyond the shadow of doubt that liver cancer is really important here. The numbers, we can argue how much. We heard from several speakers. They kept reiterating that we know the risk factors. Then you see different progression in the efforts to prevent according to the risk factor. So Dr. Turner's actually is quite advanced. Like, many states don't have demonstration projects that shows that this thing works. Well, we have one and actually several others that have reached to a point where, hey, you could do it. And I love in your slides what is needed for sustainability. So we're fairly advanced there for a hepatitis elimination plan that is at the level of the state, that one can give them sort of almost the recipe for what it takes to sustain demonstration projects. But you've heard also about non-alcoholic fatty liver disease, and a beautiful futuristic talk about what we can do and what we can't do, but haven't proven effectiveness and efficacy and all of those things. So this is maybe early, and it seems like the deficit there is most people don't know anything about it. I mean, I remember when I gave my early talk, and I said 1 in 3 and 1 in 4, and I see a couple of heads, and I'm like, really? Well, most people don't know that. So I believe we have someone here in the Department of Health here in Texas. Is this right? Can I call them out? Yes, here she. Yes? Okay, the Houston Health Department. I mean, someone from, and I know I talked to several of you, and maybe you can share with us your perspective. What are the issues that face you in hepatitis elimination, for example, to sustain the efforts at the level of the state?
Sure. I'm Stephen Pont from the Department of State Health Services. So thank you for the invitation to be here. And I've been with the health department about 5 years. Prior to that, I'm an academic pediatrician, primarily focusing on childhood obesity and community health. So the primary prevention aspect of this topic is of particular interest there as well. So I think that everyone, I think, in America and the world is coming off the COVID hangover, and certainly us at the State Health Department and our colleagues in Houston and in public health all over have been dramatically affected from the COVID aspect that just further highlighted the disparities that existed before that certainly have lots of overlap with the factors that are at least partially causing the high rates of hepatitis C and hepatocellular carcinoma. So from our standpoint, yeah, I think we're very interested in that. We're a helpful partner in wherever we can. I think we're public and population health, so more on the prevention side, and certainly thinking about how we can help people make it be easier to make that healthy choice to have more of the prevention aspect. And I was curious from the presentations if anyone can unpack a bit more on, particularly in the South Texas and in the higher prevalence in Latino populations, what the thoughts of drivers are of that. Is it income? Is it health behaviors? Is it a genetic predisposition?
Sumit or Barbara? Would you like?
No, I think it's a combination of everything that you just highlighted, and the question is, how much can we impact all those different aspects? So even like now, it's we're seeing, families of patients with fatty liver, families of patients with cirrhosis, family of patients of with liver cancer also, and so yes, there's the genetic component. There's a lot of studies going on in that, but beyond that, on top of that, you add sort of the income disparity, access issue. I think that just compounds it even more.
And if I could, to just add, we're also recognizing that this disease process is starting earlier in age. We now have childhood obesity, childhood fatty liver disease. So it's also impacting the children too. So we're talking about decades of disease exposure.
Our anecdote is related to one recruitment site in McAllen, Texas, where we recruit patients with cirrhosis for our consortium. And we're struck that the vast majority, by vast majority, I mean 80% plus, don't have hepatitis C or hepatitis B. And you could track it to alcohol or non-alcoholic fatty liver disease in that area. And honestly, if you go to McAllen, you would figure it out very fast as soon as you land in the airport or go to the hotel. I mean, the phenotype of both alcoholic and non-alcoholic fatty liver disease is so prevalent, it's stunning, actually.
That's right. And I just want to build on that we, at the end of our project, started to transition into wanting to evaluate people with abnormal liver function tests, let alone, hepatitis C. And the docs really pushed back. Said, but everybody has abnormal liver function tests. We can't manage this. And it's a, the steps and the thought process of how to do that efficiently was nowhere near being operationalized. So I think that's another really big opportunity, although again, I am dispirited when I have obese patients sometimes because it's such a tough road to hoe, unfortunately.
So we have a question here, then Dr. Conwell, then the Houston department. So the mic is, please.
Great, thank you so much. Good morning, everyone. My name is Adrian Simmons. I am the Director of Programs at the National Viral Hepatitis Roundtable. We're a patient advocacy organization. I'm a pharmacist by training, but my vantage point is really viral hepatitis. And so I have both a comment and a question. My comment is that, we heard Dr. Azrani in your talk that cirrhosis has a new face. Hepatitis C certainly has a new face also, right? So when we're thinking about the populations that are disproportionately impacted, I was struck that people who use drugs has not come up in harm reduction being a strategy for prevention, which is really, really critical, right? We can't treat our way out of the hepatitis C epidemic. We've also got to have adequate prevention strategies like harm reduction. So that's something that struck me. My question, though, is around, we've heard a lot about EMRs, and I'm curious, Dr. Fortune, Dr. Turner, if you have any comments around, we hear feedback from providers around alert fatigue. And so in the context of a universal screening recommendation for hepatitis C, there are certainly ways in which we could leverage the EMR, but providers are inundated with alerts. And so I'm just curious if you have any experience about how to optimize that.
No, you're absolutely correct. I mean, there are many demonstrations of the alerts leading to immediate basically lack of utilization after like 2 months of implementation. So, and that's the point of ongoing feedback with your providers. I think 2 parts. Number one is not make it just an alert function, but more of a pathway to care for them function. So we're actually helping the providers with the ability to, what do we do? Basically a virtual hepatologist is helping them in the EMR directly to say how to manage the patient. So to me, that is helpful as opposed to just telling them, hey, this person might have fatty liver disease. Number 2, I do believe notification of the patient about their potential possibility of having advanced liver disease is important. And that, I think, is an appropriate alert in order to engage with their doctor so that we can close the loop and have a better rate of linkage of care. Because a lot of times, even when the doctor does recognize advanced liver disease with the patient, there's still the lack of connection of patient following up. And you saw that kind of upside down pyramid. It actually is even worse when you think about patients with more vulnerable discriminants of health. So So I think it's twofold, and that's the point of kind of having ongoing provider input in the design of EMRs, which I think was the problem in the very beginning. And so we do need to make them more provider-friendly and patient-friendly.
Yeah, and one tag team. I wish this were a team sport, because I wish all of the alerts didn't come to me, you know? I would like to have a care manager, if it has to do with chronic liver disease, that it goes to somebody else, so I'm not the only person to deal with all of it. I'm telling you, the EMR and the portals are killing us. And one of the things that worries me about going straight to the patient saying, you have chronic liver disease or may have chronic liver disease, is they go, ah, you know, and then I have to deal with the fallout. So I think it has to actually be very well in partnership. I agree. You want to answer?
Yeah, no, that gets, again, that's my point, is having this kind of, layered out phases and strategy. You're absolutely right. The portal fatigue on providers and how they're spending 3 hours outside their work for every hour of clinic is very relevant and very important. And so that's my point, is making it more sophisticated and more patient-friendly.
And a team. So again, and I think if we could offer a little education when we send a note out like that, maybe, you know, chronic liver disease has to do with something that's really treatable, or some, you know, nice things that go along with it. But as I say, a lot of the patients, and I'm out in LA and we serve at LA County, a lot of uninsured, they are not on a portal. They're still, we just, you know, that's why Epic is wonderful as a dream and the VA is wonderful as a dream, but I'd love to get policymakers involved in thinking about how to really bring in all of these other settings that serve really the low-income vulnerable populations.
Yeah, I mean, there's other patient communication devices, even through texting can be done through a HIPAA-compliant app.
That's right.
So there are other modalities that don't have to necessarily, they can be connected to EMR.
That's a great idea.
But they don't have to necessarily be EMR-based.
As far as the other high-risk groups for hepatitis C, we're going to hear a healthy dose of that about the PWIDs and the prison populations during the lunch hour. So there's a progression in this talk. Dr. Connell.
Great session so far, very insightful. Dr. Turner, I think your presentation, I would echo what Dr. Thrift said, really bringing us down to the practical realities and many, many barriers that there are for eliminating hepatitis C. It's focusing on that. So if we want to think to the next step, think a little big, and if we are thinking towards having a state-level policy change, having a state-level elimination program, the lesson that you learned, how do you think they will inform that plan at the state level? What are the few things that you would want to have the policymakers know as they think about the Texas level plan, having that plan and also implementation of that plan, which I can imagine how challenging it would be. It's not going to be one size fit all.
Mm-hmm. You know, to be honest, I don't know a whole lot about the state plan right now. I'm sure that Dr. El-Serag does. None, but I have to say that I would like you to target the state plan. What it bothers me a little bit, and feds do this too, is they focus on Kaiser and big systems that are, it's like the rich get richer. And I feel very strongly about FQHCs being partners. I've tried to get them sort of involved in all of this, but again, they have so many other priorities that if you can figure out how. The other thing is to not make a liver-specific support, because we talked about obesity. If you could get the team that you're supporting for value-based care for liver disease to also help me deal with obesity, that would be a win-win, or diabetes. I mean, in other words, don't think about silos, but think about how it overlaps with all these other conditions. And sorry, I didn't mention substance use treatment, even though I'm really passionate about it. That was one of the things that prevented the Care Cascade from going ahead. I know you're supposed to treat everybody no matter what, but substance use was a problem for us in South Texas, and we didn't want to start people on treatment they wouldn't adhere to. And I know there's good data that they will, but it is still a problem in South Texas getting access to that. Sorry.
I would echo that kind of request for the afternoon, because that's what we'll be asking over and over again. If we had to go to policy changes, what would be the one or two big ticket items that would focus on? And obviously, we don't know, and that's why we're talking today, but it's a legitimate question. Dr. Thrift?
Right, so like I was saying on my talk is you develop a consensus care pathway, which can be integrated as, for example, metabolic health pathway. You're absolutely right that, fatty liver disease is only one organ of the whole spectrum of other diseases, including cardiovascular disease. The red's still around. But no, that's the point. Is I think with ongoing group discussions involving patients, primary care providers, specialists, other stakeholders, I think it's very important to create consensus care pathways that everyone adheres to, and then we can actually embed that within the EMR. So when it's alerted, it's not just I'm alerting you, I'm actually going to do something about it.
So we're actually currently...
Yeah, you have a good example.
Yeah, well, we're at this implementation phase throughout our system in Dallas, we realize it's not one size fits all. Yeah. And so we're trying to target 3 different kinds of clinics. One is sort of the ones that serve underserved. Second is rural. 3 is sort of, have insurance, no issues. And we're actually going to our primary care folks and saying, okay, what exactly do you need? For one group, it might be, I want a dashboard, an MA in the clinic will run it and then discuss with the PCP. The second one is to your model. So we're working with, Dr. Zohar, who's in the audience, of sort of, we have a hepatologist who goes there and once a month we'll review, the cases and have this mini consultation. And for the third, sort of the private insurance, it's this e-consult mechanism. So I think, this kind of approach is going to vary, and we'll just have to try it out, and VA might be a different way to do it.
Yes, Dr. Kadri.
Yeah. Good morning. I'm Sayar Kadri. I'm a hepatologist here at Baylor. And we've had an ECHO program for going on almost 10 years. And so I don't know if this sounds dramatic, but it really made me sad that I think one important thing that Dr. Fortune also pointed out is that we've had this ECHO program, and we've seen the number of patients being presented has dropped off. And we thought maybe primary care just isn't interested in anymore, and I know the need is there. And so I think we missed that feedback, because I'm sitting here, I have an ECHO program, 1.5 hours every week, right? And it's not working for some people, clearly. And so we missed that feedback, and I think it's important to get that from the people on the ground, right? So that's one point. The second thing is, like you said, we need a champion in those clinics, and the clinic has to support that champion. So not everybody's interested, not everybody has time, and I totally understand that. But usually a clinic can find one person that is interested, and then that office has to support them. In some states, primary care physicians, providers, they get paid to present their patients in ECHO, and that's a great incentive. So I wish we could do that for our providers as well. The other thing, I have this great advantage where my college supports me for doing ECHO. So nobody questions why I'm not seeing a fatty liver patient while I'm doing ECHO. So I think that's important too. As a specialist, I have great support. So in Texas, I'm here. ECHO at Baylor is here to help whomever. And the other thing is, I don't just do Hep C. So we do Hep B, and I did a PBC patient the other day. So when my providers come and say this patient has cirrhosis, or I don't know, the liver enzymes are elevated, we work with them and we help them figure out, like a PBC diagnosis just recently. So I wish I could reach out to those people, or you could put them in contact with us, because we've got a thriving ECHO program going on 10 years, almost 3,000 patients that we've seen. 60% uninsured. And I honestly tell my people, the people that are participating, I've learned so much more from them than they've learned from me. Because, like you said, it's reality. And I work at a place where people have insurance and they have some money, but that's not where the sickest patients are and the most needy patients.
Well, thanks for saying that. What I didn't mention one thing is that once you get people, the PCPs and their team past trying this out, it's so exciting to cure something. Because we have so many diseases like diabetes, like obesity, that we have a hell of a time managing. And this is very rewarding for people. And so once you can get them past that stage, usually it is one person in the clinic. I have to say that other clinic providers kind of go, yuck. And until we have something that makes them really care about it, I think it's a problem. But if you can find those people who are willing to try it out and see the wonderful success, but they need that team. There's no way you can put it on a dock in a box without the team. I just feel like you're doomed if you don't have that.
I thought your presentation nailed it. I mean, it's a competition for resources.
Yeah.
Everyone thinks their disease is the most important, and they're probably all right. And what makes your reminder better than mine, if you're paid for it or if it's a quality metric? And we are so fortunate to have the CMO of United Healthcare community plan here with us today, Dr. Deshpande. So he's the payer's perspective. And between the payers and the policymakers, if we do it right, the providers will be incentivized to do this. In a disease where the information is ripe. There's nothing to guess about hepatitis C anymore. There's a lot to guess about NAFLD, I'll give you that. I mean, if a payer says, hey, this is way too far, give me demonstration, I would understand. But Hep C and Hep B, just do it kind of thing. And the do it part cannot rest on volunteerism. I mean, it's beautiful, but you can't cure hepatitis C based on someone who's well-intentioned. I have a question. Yes, Dr. Ward.
Okay, thanks.
And then one last one,
Okay,
and then
quickly.
coffee.
Okay, great presentations. John Ward, I'm with the Task Force for Global Health. I was formerly at US CDC, where I was the Director of Division of Viral Hepatitis, and had the pleasure of working with a number of people in the room. And so these are great presentations. I had a question for Barbara. It seemed like a lot of what you were raising were the complexity of the system more than the complexity of the disease. I mean, around the world, there's been this huge move toward simplification of HCV treatment because of the safety of the drugs and their high impact. And, and this adage, 60% adherence, 90% cure, even for hepatitis C. And so it's really, makes a big case for simplification. So is my assessment correct on that, or did you actually, in your own trajectory, see that simplification is happening for HCV care? And then I had a question for Sumit in that, this issue about a reminder fatigue is legitimate, but it's because physicians, they're going to rank what they think is important, and they don't think liver disease is that important, so they'll just disregard that particular reminder. So is there any change in medical education that's increasing the emphasis on liver disease and the importance of early diagnosis of liver disease, so that when those clinicians actually go into practice, they don't disregard that health alert anymore? But thank you, Barbara. Thank you, Sue.
Yeah, I have a quick answer. Over the years of our project, it got way simpler with pan-genotypic drugs. So that was a huge advance that made it all so much more straightforward, and short course therapy. So I think the complexity is implementation, not the disease, And I want to make it clear that it's got a lot of components that have been pointed out by all of us. And if you ignore that complexity, you're not going to get to managing a disease, which is actually really quite straightforward. I agree. It's kind of like sailing, though. Sailing is like, all the time. And then a wind comes up and you have tough patients who are complicated, and that goes way above my pay grade. And people get very scared, the PCPs do, if they run into that. So you've got to have a good relationship and a place to send people when things get very complex. That was a bit of a problem in our practices because they were uninsured.
Several components. One is, at this point, education is still one-on-one. I think we have to target every single practice in a different way and say, what are your needs, and let me give you that information the way you need it. That's one. Two, from the patient perspective, we're actually empowering our patients more. So in our clinic, it's videos that we've created on these topics that are on autoplay. While they're getting a tap or getting fluid taken out, it's an autoplay. So then they sort of spread the message also, like, hey, what is this liver disease that you're sort of talking about? And at the system level, we're making the economic argument. We're saying that in about 3 years, you're going to have, huge number of fatty liver medications. How are we going to adjudicate who needs it, who doesn't need it at the system level? Help us identify these patients early. So that's sort of the system buy-in. And then in terms of that epic fatigue, like I was thinking about it, it's like our kids used to mow yards. Like maybe if I could just pay them $20 and look and clean up my Epic inbox, I'd be happy, but I'm not allowed.
One last comment here before coffee.
So yeah, I'd like to make a few comments. I'm Jeff Zohar, and the perspective I bring to this is, as a practicing internal medicine pediatrics physician, I appreciate the specialty in the room and the perspective that you bring. At the front line, I want to echo everything Dr. Turner is saying. I think this is so critical. My experience has been treating HIV/AIDS in Africa with Baylor College of Medicine 10, 15 years ago. We had frontline caregivers giving specialty care in high-risk, high-need situations. And then bringing that to the United States with federally qualified health centers, you have primary care doctors that are giving this care that we'd love to have the specialty access that we are describing here, but that doesn't always functionally make it there. I think where we are now is you've so eloquently illustrated this idea of a care team model where you have care managers. We've been very fortunate to have integrated care teams that include behavioral health, because we talk about substance abuse, depression, why are we drinking, alcohol. These are all drivers that behavioral health is a huge factor. Pharmacy, chronic disease educators. This is a team-based care. So as we're evolving in our healthcare model, we can provide the best care at the level of the clinic where our patients are coming in. And these components of care that we're describing need to be at the level of the patient, at the community level. And we can do it. This needs to translate into health economics. It needs to translate into how is this so much more affordable for our states, for our government, for our hospital systems, that why aren't we, to Samit's point, taking this all the way back to let's treat obesity, not end-stage liver disease and hepatocellular carcinoma. Let's treat our sickest communities and give them resources to do that. That is policy, and I'm glad that we're talking about it, and I think we have the right people here to do that. So I value everything you've said, and I want to echo that I think that we're on the right track.
Thank you very much. Thank you, everyone. Coffee is in the back. We'll resume exactly 10:20 and probably a few minutes before that so we can stay on time. Thanks again. Thanks. All right. If you can make your way to your tables. We're going to start the next session. There we go. Ariel, help me out. I have to call people out. Dr. Thrift, can you sit down? All right. Remember, a minute saved now is a minute saved later. It's all coming out of your bank account. All right, so if you would please make your way back to your table, we're going to start. I'm going to start with the great news. We found Dr. Singhal. He's here, and he will be moderating the next session. My other announcement, by the end of this session, after we do the discussion, there will be a group picture. Everyone in this room, you'll be lined up here, and we'll take pictures, okay? So Dr. Singhal. Dr. Singhal is the director of the liver cancer, director of hepatology at UT Southwestern. He's still wondering, is he Dr. Singhal or not Dr. You are Dr. Singhal. You are? Fine. I'll just come in. Just come back before we lose you here. He will be giving the next talk. Dr. Singhal is funded by CPRIT and NIH and several other places to study liver cancer. He's one of our local, but also now national and international experts on liver cancer. And today he will talk about the early detection part of the spectrum. Dr. Singhal.
Thanks, Hashem. So I know that Hashem thought I showed up late because he thought I liked sleeping in, but it was meant to be symbolic and purposeful. So it was meant to symbolize that we're coming into the liver cancer fight late, but not too late. We still have a chance to win this, and that's why I showed up 5 or 7 minutes late. So let's see. So I was assigned to talk about detection, diagnosis of HCC, and really implications for healthcare and health policy. Here you can see my disclosures, and I will tell you when it's relevant in terms of the slides. So once again, I'm going to start with just some basic epidemiology to highlight some of the facts that we heard this morning. But I know that we've heard a lot of information, and I think I'm going to try to distill this down into a couple slides. When we think of liver cancer mortality and burden here, I think some of these are the facts that we need to remember. We need to remember that this is already a common cancer, and we're going in the wrong direction in terms of mortality. So here you can see the top 15 causes of cancer death in the United States from the SEER database. And we've seen notable improvements in terms of mortality for most common cancers. So these are the ribbons that you see across all of the months: lung cancer, colon cancer, breast cancer. We're doing a better and better job because we're finding these cancers earlier, and we're able to have more and more effective treatments. And you take a look at this, and in the red bars, you see the cancers where we're going in the wrong direction. Pancreas cancer, brain cancer, and you can see by far leading the way in terms of the wrong direction is liver cancer mortality. This is rapidly increasing when we think of this from the United States perspective. Now, of course, as a non-Texas native, sort of somebody who moved here now about 12 years ago, I recognize Texas is Texas. It's part of the US, but it's different than the US. And whenever I give these talks in Texas, we always have to highlight what is it here in terms of Texas. And this is a problem here in Texas. So this is a common cancer here in Texas, and we're once again going in the wrong direction. And this is one of the cancers where we're going in the wrong direction across all different subgroups. So it doesn't matter if you're non-Hispanic white, Hispanic, non-Hispanic black. It doesn't matter what racial ethnic group you are. It doesn't matter if you're male, female, et cetera. These incidence rates are increasing, so this is a cancer where we need to solve this now. 5-year survival for cancer. So once again, going back to sort of a different way to portray the same idea on the first slide, we've seen notable improvements in terms of cancer survival across most common cancers. When you take a look at what cancers we're doing poorly in, liver cancer mortality started poor and it remains poor over time. So this is one of the few cancers where the 5-year survival remains below 20%. So when we think of this, now, once again, we all know sort of that Ben Franklin adage, right? An ounce of prevention is worth a pound of cure. And so you heard from the morning sessions all about primary prevention. So these are preventing in terms of, Sumit's sort of nice mnemonic in terms of repeat. So we're finding these sort of, risk factors. We're trying to intervene upon these risk factors so we can prevent the development of liver cancer, curing hepatitis C, treating fatty liver disease, et cetera. This is by far the best paradigm that we can do moving forward. However, it's not going to be 100% effective, and we're not going to solve this in everyone. There are still going to be some patients who progress to developing chronic liver disease, advanced chronic liver disease, and will be at risk for developing liver cancer. And so when we think of the prevention paradigm, there's primary prevention, which you've heard about, and then there's secondary prevention. So finding these cancers at an early stage when we can continue to do better. So this still falls under that same paradigm of an ounce of prevention is worth a pound of cure. And so this is the other aspect which we need to focus on if we want to do a better job in terms of reducing HCC mortality. So now, why would we ever do HCC screening, right? So this is something which this doesn't get the same press as colon cancer screening, breast cancer screening, but I'm gonna start by talking about some of the evidence base for this, and then I'm gonna talk about some of the failures in terms of why we're not doing as well as we should. So whenever we think of cancer screening is to improve survival, to reduce cancer-related mortality. And you can see here from sort of a face validity perspective, there's a strong differential prognosis if you're found at an early stage versus a late stage. When we think of liver cancer, at least when I think of liver cancer, I think of this in the same camp as pancreas cancer. Highly fatal cancer. It's one of those few cancers where you're like, I don't want to get that because there aren't the survival is poor. But what we don't think of very often is if you're found at an early stage, this is a curable cancer. So we have things like liver transplantation, surgical resection, ablation, where we can actually go in and burn this cancer. And these are curative and associated with a median survival greater than 10 years. And the reason we think of liver cancer as being such a bad cancer is because we continue to find people at late stages when we don't have those curative therapies. And you're gonna hear about some of the exciting advances that we have in therapies, and I'm all into that. Like, I think the advances in terms of therapeutics are amazing. Immunotherapy, as you'll hear about, amazing. But despite that, the survival is still 2 to 3 years. So when we think of this, and you think of a liver cancer, it doesn't matter how much we improve the therapeutics, the biggest differential is finding people early when we can cure cancer, and so that's what we need to focus on. So, professional society guidelines recognize this. They recommend HCC screening. This has been built into sort of many of the professional society guidelines, including those from liver societies and from cancer societies. So built into the NCCN recommendations, built into the American Association for the Study of Liver Disease recommendations. This is something where people who are involved in this field recognize this. However, it does not have USPSTF recommendations. It doesn't have broad recommendations outside of these societies that are intimately aware of these data and intimately involved in this space. Now, professional society guidelines recommend or identify target populations for screening, including those with cirrhosis. And I'm not gonna go through the epidemiologic data for this. You heard some of this from this morning, but these are patients primarily who develop liver cancer in the setting of advanced chronic liver disease, typically cirrhosis. Over 80%, if not over 90% of patients who develop HCC in the United States as well as Texas do so in the setting of cirrhosis, so we have an identifiable target population. This is something we can do. And this is the typical pathway for which this happens. So you can have one of the many chronic liver diseases you heard about this morning, viral hepatitis, alcohol-associated liver disease, non-alcoholic fatty liver disease. You develop chronic hepatitis. A portion of these patients go on to develop cirrhosis. And once you have cirrhosis, you have an annual risk of developing HCC of 1 to 3%. So that means that if you have 100 people, 1 to 3 of those people are going to develop liver cancer every year, cumulative over time, which means in a period of 3 to 4 years, you have 10% of that population who develops liver cancer. This is a very, very high-risk cohort. This is where we need to target our screening population. You've also already heard about some of the dramatic improvements, although incomplete work still, in terms of combating viral hepatitis. this is really more and more of a disease of non-viral etiologies, both alcohol and non-alcoholic fatty liver disease, common conditions here in the state of Texas. So what are the data for HCC screening? So, we have a large randomized control trial in chronic hepatitis B. This was conducted in China. I think we all recognize that chronic hepatitis B, sort of patients from China may or may not reflect those patients from the United States. But there are several studies now, both in the United States as well as in Europe, that show a strong association between the receipt of screening, and I'll talk about how we do this soon, but the receipt of screening and improved clinical outcomes. So those patients who receive screening, significantly higher likelihood of being found at an early stage, significantly higher curative treatment receipt, and reduced HCC mortality. So you see here, most notably, we want to reduce mortality from cancer, improve overall survival. You see a 36% reduction in cancer-related mortality if you receive HCC screening versus not. So there's a strong association between screening and improved clinical outcomes. Now, okay, fine. Let's say you buy everything I've sort of sold you so far. You're like, yes, I understand we should be doing this. HCC screening is good. Now, how do we make this effective? How do we do this, and how do we make sure that it works in clinical practice? And I would argue that this really depends on primarily two things to happen. First, we need to make sure that it happens, so screening utilization, which I'll talk about for the last part of my talk, and having effective tests. So if you do this, you need a test that works. So what do we do? How do we do this? The nice thing is that HCC screening is actually used or is performed using an abdominal ultrasound with or without a blood test called alpha-fetoprotein. Now, these tests, important to note, these are readily available. So it's not like we have limitations of ultrasound availability or blood test availability. So this isn't an MRI where it may be difficult to get in rural communities. Ultrasound is everywhere. Ultrasound is cheap. Ultrasound is non-invasive. So this is a test that is easy and can be performed. So what's the data in terms of ultrasound plus AFP in terms of how well it works? So when you take a look at this, you take a look at all of the studies that have looked at ultrasound and AFP in terms of finding this at an early stage. Ultrasound and AFP detect the vast majority of tumors at an early stage. Over 2/3 of patients are found at an early stage if we perform ultrasound and AFP. It's not perfect, but it is an effective modality to find liver cancer at an early stage. Second, there have been decision analyses that have compared this to no screening, and we know that it's cost effective. So ultrasound and AFP was cost effective in the vast majority of simulations in this cost effectiveness analysis. So this is effective and cost effective. There, once again, in terms of the sort of paradigm of assessing this, this is a good strategy moving forward. Now, of course, we know that it's not perfect. I told you that it can detect 2/3 of liver cancers at an early stage. We would all love to have something that would find 80, 90% of liver cancers at an early stage. I'm going to show you a couple slides, not because I think it impacts policy today, but I want to show you what's around the corner in terms of other modalities that may be coming out in case you're like 2/3 isn't good enough. There are other strategies that are being evaluated which can augment what we have available in terms of ultrasound and AFP. So here you see a study that was done now about 5 years ago, looking at MRI-based screening modalities versus ultrasound-based modalities. Prospective study followed patients with cirrhosis over 1.5 years, and you can see that MRI-based screening was more effective in this study than ultrasound-based screening. And I say this not because I think MRI-based screening is the answer for everyone. There's no way that we're going to go to McAllen and say, put every one of your patients through an MRI every 6 months. However, this is something where it provides a framework which we can build off and augment what we can do by ultrasound. So this can be used in some centers to augment what we can do with ultrasound, particularly those in whom ultrasound may fail. And the second is that we're pretty good at innovation. So, what we can do is, and there have been studies that have looked at this, an MRI is a 45-minute exam. There have now been studies where you take selected sequences and you can do an abbreviated MRI, and you can do this in 15 minutes. And so if you're able to show that this is effective, which there are some early data showing this, This may augment what you can do in some larger cities where you have MRI capacity, Dallas, Houston, Austin, et cetera. So once again, promising data of we are trying to innovate and improve that test effectiveness as we move forward. Of course, as I mentioned, we have to consider issues of MRI capacity, costs, and so this isn't going to be the answer to everyone, but I do think it can be helpful in selected patient populations. The other thing, and this is this is where my conflict, I do consult for this company, and I don't necessarily think that this specific biomarker is the answer per se. This is more so as an example. But we and others are working on biomarker-based screening. So this is really taking a look at promising biomarkers. This is one of them. There's liquid biopsy techniques, many biomarkers that are coming to market over the next several years, which would allow us to go from an imaging-based strategy to a blood-based strategy. Now, of course, this solves many things, right? You may be able to either keep test effectiveness or increase test effectiveness, but you're able to do this easily. So no longer do I need to come back for an ultrasound a different day. I can just get this when I see my provider and get it the same day, so you're able to augment what I'm gonna talk about soon in terms of test uptake. And I show this slide basically to show that these biomarkers, although early data, are promising. So you can see here when you take a look at the second, fourth, and sixth row of this table and just focus on the first column, you can see that this biomarker panel is able to achieve sensitivities of 60 to 80% for early stage detection. So this biomarker is able to detect 2/3 or up to 4/5 of liver cancers at an early stage by itself. Once again, early data, we need these to be validated in other sort of studies, but this is promising, and we see similar performance for other emerging biomarkers. Once again, in terms of Texas is leading the way in terms of validating these cohorts. So there are 2 national, large, multi-center sort of cohort studies that are being done, which will allow validation of these biomarkers, one of them being funded by the NCI, the other one being funded by CPRIT. These infrastructures are now allowing validation, which will allow these biomarkers to hopefully come to market soon. Last couple slides here, and then I'll be done. In terms of, I talked about test effectiveness. The other thing that I want to talk about is obviously we need to make sure this happens. And so this is the other aspect in terms of making sure that we're able to have effectiveness in terms of reducing mortality. And this is an issue that we need to solve. HCC screening is underused in clinical practice. Here you can see several studies that have evaluated this. So this is a systematic review and meta-analysis of those studies. And when you take a look at this, when you take a look at overall, only 1 in 4 patients with cirrhosis undergo HCC screening. We clearly need to do better. And when you take a look at this, it's worse if you have non-viral liver disease. It's worse if you're followed by a primary care provider, and worse, I mean lower. This is where the war is being fought, and this is where the war is being lost. So we need to do better in terms of increasing screening in terms of these areas. Now, I can give a 45-minute talk, which I'm not going to, Hashem. I can give a 45-minute talk on just this aspect in terms of what we need to do, all the barriers. I'm going to simplify it in terms of one line. There are patient and provider barriers, both sides of this, in terms of why this doesn't happen, and we need multi-level interventions to solve this. And I'm happy to sort of go through this in the Q&A, but it's a complex issue, as many of you would imagine, that we need to solve. And here you can see one study in which we did this, and we broke this down into, we think of HCC screening, just do it. But this is a multi-step process. You need to identify the patients, you need to recommend this, patients need to have this done. And when you take a look at this, there are failures across that entire spectrum, or in terms of making this one step, even a larger cascade, happen. And so once again, highlighting the need for multi-level interventions across this entire cascade to make this happen. One of the key things here, and you've already heard this morning, it's hard to recognize that at-risk population. I would argue, Barbara showed this very nice sort of study that, I had the honor of being involved with her in terms of identifying hepatitis C, curing those patients, and we would recognize some of those patients as having cirrhosis. I would argue, much like Sumit pointed out, identifying fatty liver, we're in a completely different game and a harder game. I mean, we passed, quote unquote, past level 1, and now we're into like level 8. I mean, this is a hard game to fight, and we need to sort of think through how we're gonna do this. But multi-level interventions are the way we're gonna solve this. There have been studies that have looked at interventions. I'm not going to go through each in detail, but I just want to highlight that there have been attempts in terms of looking at the efficacy. So how well do these work in a study population? But there have been very few studies that have looked at implementing these in clinical practice and now seeing the effectiveness as we roll this out into routine clinical practice. And this is going to be one of the next stages of what we need in this area. So in summary, at-risk patients include those with cirrhosis, and as you've already heard this morning, we're seeing this shift in terms of the epidemiology from a viral to a non-viral world. And this is important to consider across the board as we think through prevention, screening, and treatment. HCC screening has good data, imperfect, but good data showing that this is effective. Right now, we use this using simple, readily available tests, ultrasound and a blood test alpha-fetoprotein. We have novel things coming around market which will be better. We'll have to think about how we implement those in clinical practice. We need to do screening. It's underused, and due to multiple sort of patient and provider barriers, we need to think through what interventions, multi-level interventions, can be performed to improve this. And I think that what we really need in terms of, I would argue, is continued generation of high-level data evaluating the screening benefits and harms, this idea of overall value. And I think that this is going to be critical because we need to move beyond professional society guideline recommendations, and we need to really focus on the idea of getting CPRIT recommendations or NCI recommendations or USPSTF recommendations, broader recommendations that will speak to our primary care colleagues, so it's not just a subspecialty battle. Thank you so much, and I'll hand it off to Samit to invite the next speaker.
Thanks, Amit. So far in the morning, we've talked about prevention at the risk factor level. Now we're talking about screening for HCC and where the barriers exist there. And now we're going to sort of pivot in terms of treatment. And I'll set up the stage a little bit for both Dr. Kasab, who's going to speak, and Dr. Rich, and I'll share a few thoughts. Yeah, that one's right. So Hashem asked me, he's like, you know what, you're surrounded by 3 experts, Dr. Kasab, Dr. Singhal, Dr. Rich. This is not your field. What can you do? So I said, okay, if I had to create a children's book or a picture book on HCC treatment, how would I do it? So I said, okay, this is my attempt, okay? So if there was a children's book, how would it be? So cirrhosis and liver cancer, we talked about this. And as Amit pointed out, is, most are in that red box. Most don't get detected early across the world. But the goal is to move, patients from that red box to that green box, right? How do we, change our paradigm so we're detecting and diagnosing early in terms of liver cancer? And what are the principles of liver cancer treatment? And you'll hear more of the details, but this is sort of the framework. You have sort of 3 pathways that happen at the same time. If somebody has liver cancer, again, the stipulation is that, I caught them early. What are the 3 things I'm going to think about? From the cancer therapy standpoint, it's, do I take this cancer out, or do I cauterize it or give it local therapy? From a transplant standpoint, and for the non-medical audience, with transplant is a cure for liver cancer, and I'll get into that, is it will treat the cancer and the liver disease. And the question in our mind is this patient ever going to be a candidate for transplant? Never, now or later. And then the third part is treating the underlying. Can we treat the cause, and what liver maintenance do we need to do? So we're sort of doing these 3 things simultaneously when somebody comes in with liver cancer. And like any other cancers, at this stage, therapy is and can be protocolized because of the work that's been done. So that's the blue thing is the liver, the yellow thing is liver cancer, 1 versus 3. So if you have that, based on tumor size, tumor characteristics, patient health, liver disease, we can decide in a multidisciplinary setting. So same kind of concept, the care team concept that we talked about in screening and prevention applies here also, is now your team has shifted into hepatology, surgery, oncology, radiology, and the core sort of driver of all this is shared decision-making, multidisciplinary tumor boards to sort of help decide, what do I do with that 1 spot, what do I do with that 3 spots, and think about therapy. And option A, somebody comes in really early, liver's pretty stable. Your sort of options are, I can cut it out, or I can try to treat it locally, or some form or the other to take care of it. And maybe that's all this patient needs for cure. Option B is I have multiple spots. What I can do is go in and try to cauterize it, or put in chemotherapy directly to the cancer, put a catheter into the liver, give chemotherapy, give radiation. And in some patients now, that's all you need. But in most patients, this sort of serves as the bridge to get you to transplant if the patient is a transplant candidate, because you're basically trying to buy time in this kind of multiple or progressing option. And then C is a transplant. And what transplant does, in this case is pretty unique, is that one, it can treat your disease, right? If it's cirrhosis, it's gone. And two, it can cure the cancer. So if we catch it early enough, then that's it. There's, of course, the asterisk of recurrence, but in most cases, if things go well, you do it early enough, you're in this option. And so what happens is when somebody comes to a transplant center is they wait for a transplant, but during that time, what we're trying to do is manage the cancer. The word we use is downstaging. So if somebody has significant burden, then you try to bring it down to a manageable level and sort of keep things stable. Or reminder that still even at this stage, about 15% of patients will progress regardless of what we do, and this hopefully will change over time. And so what happens is once somebody hits the door and has liver cancer, at least at a large center, again, you're doing those three things at the same time. The treat cancer, evaluate for transplant, treat the underlying. From the treat cancer, again, the decision is, is this stable enough to cut out or cauterize? Do I give local therapy? And then in both those cases, these patients sort of fall into this cycle of imaging, visits, retreatment decisions, tumor board every 3 months. Second is evaluating for transplant. So this patient has to have access to a transplant center. And then you think about, okay, what's the best option? Living donation, deceased donation, and what if these patients progress while waiting? What can we do? And the third is having a team to help treat the underlying. For example, treat the hepatitis C. And again, the question becomes, is the liver healthy enough to continue treatment? And as one can imagine, is throughout this whole paradigm, there's going to be gaps at every single level. Did this patient get ID'd early enough? Did this patient have access to uniform tumor boards across Texas? Did this patient have access to transplant? Is the infrastructure there for monitoring, labs, imaging? Hope the patient doesn't lose insurance, because otherwise then what do we do? And then hope the patient doesn't progress, despite our best efforts. But if you can sort of navigate all these things, cure is possible. So now I'll hand it off to two speakers. First one is, and I'll introduce both of them right now. So first is Dr. Kaseb. He is a medical oncologist at MD Anderson. He has trained in Cairo, he's trained in Detroit, he's trained in Michigan, and for the last 10 years has been leading the effort here from the oncology standpoint. And two is Dr. Rich. She's currently at UT Southwestern. She went to the Ohio State, and the was trademarked, I think, about June 2022, because it was a huge moneymaker for Ohio State. And now she's been here, and her interest has been looking at disparities by sex, gender, race, socioeconomic status in terms of treatment for HCC. So, Dr. Kaseb.
Morning, everyone. Thank you for inviting me, and it's a real privilege to be here. And in case you haven't noticed so far, how much physicians and healthcare workers love these settings. It's because of two main reasons. We love to lecture and tell people what to do. And that's actually from our patients, because our patients, they always tell us, doctor, just tell me what to do. I don't know. So, but joking aside, we all are here because people trust us with their life decisions, right? Whether we're physicians, healthcare workers, or policymakers, people look up to us to make those life and death decisions and help them with their life affairs. So, so today I'm not here to tell you what you know in terms of your established beliefs. I'm not here to reiterate and reinforce them. I'm gonna be challenging you and thinking with you. So I'm gonna be talking about briefly a few slides about what we do in clinic to treat patients, but evolve from this to stimulate your thinking and come up with some suggestions that you guys can take it to the halls of power and change policies and help us help our patients. So how do you move the slides from here? This is my clinical trial research portfolio support. So these are the objectives today. I'm going to walk through the importance of early detection of liver cancer. And on the other side of treating liver cancer, I see the heavy cost of late diagnosis, like our speakers talked about. You know, when you diagnose early on, you can offer more curative options, and I see the other end of the spectrum. So that's why I'm going to briefly talk about the importance of this from our standpoint as oncologists, and then talk about how healthcare policies can improve patients' access to care, to standard and evolving therapies for liver cancer, review the potential indicators of treatment outcome, predictors and prognostic indicators, and discuss how to help improve survival and potentially cure liver cancer in Texans using those systemic therapies. So when it comes to liver cancer, this is how we look at it in clinic. The first question we always ask is, do we have liver-only disease or metastatic stage 4 disease? So for liver-only disease, if the patients have advanced cirrhosis, the only cure is liver transplant, and this is only available for 5% of patients. And if they do have liver-only disease and no advanced cirrhosis, they can go for surgical resection, and this is about 10-15%. So only 1 in 5 patients could really be offered curative option, and even in those, I have a slide about this, 20% of those patients, 60% of those patients who get resection, they end up recurring within 2 years. So even resection itself is not totally curative. And then, of course, for patients with stage 4 disease, they go for systemic therapy. Sorry, I'm on call today. I promise I'm not going to interrupt my talk, but if you hear anything, you know what it is. So, so this is, a slide that really taps into the importance of early detection here. And you see here that those patients who are on the left side of the slide with very early disease, look at how much survival here. So those patients have more than 5 years survival if they fall within this category, early diagnosis here. And the intermediate stage, more than 2.5 years, and this is exactly why early detection is very critical. And to Amit's point, we really have to think out loud about this. The best scenario is to help primary care physicians and reward them for screening. That could be an option. We all know how much they get per patient, and they see 30 patients a day in their primary care clinics. So to enable them and encourage them to do this, maybe a healthcare policy would be to encourage them and reward them for screening those patients, so that way they can also find time and resources to do that. While the right side of the spectrum here, this is where my population of patients live. Unfortunately, this is about 70% of patients who cannot go for any surgical resection or transplant or curative options. So they end up in our clinic, and their survival is in the range of 1.5 to 2 years. So very poor survival outcome. Less than 10% live after 5 years. So this is just a snapshot at how much improvement in terms of systemic therapy we have witnessed in the last few years. This study, and MD Anderson was part of the global team leading it, established a new treatment paradigm for hepatocellular carcinoma patients with immunotherapy. So IV medications stimulate our own immune system to attack the cancer, very innovative, and this came out from many clinical trials before that led up to this. And the response rate, 30% of patients have tumor shrinkage, so they can even go for other curative options down the line if they get excellent response, such as surgery or transplant. So the major take-home point from these new immunotherapies are that patients with excellent liver functions tolerated the treatment well and had excellent response, and there was a trend towards better benefit in patients with low volume disease and patients who had hepatitis B and C. So the bottom line is we know those patients, they are frequent visitors to our hepatology clinics, so if we can diagnose liver cancer early on, again to that point, they will have good liver functions and they will respond better to our therapies as well. And this is just a snapshot at what we have other than this regimen that I alluded to. So we have other treatments here, including this one, which is immunotherapy, purely immunotherapy, and these two are also immunotherapy-based. And so 3 immunotherapy-based in the second line, 2 immunotherapy-based in the front line, and the rest of them are drugs that are called targeted therapies. So we are not treating our patients with toxic therapies. So these treatments are fairly tolerable, and mixing them with immunotherapy enabled us to have much higher response rate. And this is all thanks to advances in clinical trials, and enrolling patients into them has been also a challenge. So this is also part of healthcare policies, how to grant patients access to top-notch clinical trials, even those patients in underserved population, addressing healthcare disparities as well in patients who don't have access to insurance even. So these, policy decisions could really enable our patients with certain bills the right to access those clinical trials, such as a few years ago, we probably all heard about the right to treat, so patients had access to compassionate use access to cancer therapies, and that was passed in 2019. So the same thing here could be applicable, the right to participate in clinical trials, how we encourage insurance carriers to support this. Some of them actually, once they know patients is on clinical trial, they don't want to pay even for standard of care. So all of these things are very critical, and our patients suffer from them in real life. So all of these things I just am throwing out there so we can think about them together, because patients trust us with those decisions. So moving quickly a few slides here to talk about, how we improved outcome in hepatocellular carcinoma patients and how we can continue our march towards that goal. So I alluded to the risk factor effect on the treatment outcome. This is a study that showed, that hepatitis C patients benefited the best from certain drugs here, which was oral drugs, and this here is immunotherapy combination, and hepatitis B patients benefited best from this. So we do have some differential outcome based on the underlying risk factors, so it's important to diagnose those risk factors as well early on. They don't only lead to evolution of cancer, but there is differential outcome there, even in established patients in terms of response to therapy. And this is a study we did at Anderson to subcategorize those patients based on their liver reserve, so we developed a scoring system. And the point here I'm trying to make with this is the fact that these biomarker, studies and trials necessitate patients to undergo frequent blood draws here, so reimbursement to support patient return visits, for example, or even just the cost of shipping, those samples back and forth. All of these things are barriers to our advances in clinical trial and research, and there is no good solution for it. So we sometimes rely on our patient support services or some clinical trial partial support of it, but providing some healthcare bills to actually mandate support for patients' transportation and for patients who don't have access to clinical trials to remove those barriers is critical to advancing cancer care in the state and the country as well. So we talked here about the risk factors, the importance of diagnosis patients early on, and this is, again, you're going to keep hearing about this throughout the day, and this is just the from our standpoint as treating oncologists. And the clinical dilemma here, I talked about this briefly in patients, even those patients who undergo surgical resection, that most of them, 60% within 2 years recur. So the clinical dilemma here is that the majority recur after surgery, and there is no standard of care to help them to provide lower recurrence rate after surgery. We did this study that was the first study to tap into this population at MD Anderson, where we did immunotherapy for 6 weeks before resecting the tumors, and 1/3 of them had complete response, 100% necrosis, and they never recurred, while the rest of the patients, half of them, still recurred. So the point here, it comes to this kind of trials to lower the recurrence even after surgery for those who are supposedly are cured, is to go through this with neoadjuvant treatment, meaning treatment before surgery, and then at surgical time, we get another snapshot at the biomarkers to understand those who responded versus those who did not, and then come up with a personalized approach. And along this line, we talked about the importance of supporting those patients to not only to gain access to clinical trials, but to continue on them and finish them and follow up. And we had a lot of patients who dropped out because they have difficulty in transportation, for example, and some clinical trials and even IRB protocols would prohibit us from selecting those patients who can get financial support versus those who shouldn't, because we shouldn't discriminate, and if we're going to offer it, we have to offer it to everyone. So this is also kind of the barrier that policymakers could help us with in terms of putting our heads together and coming up with a solution to blanket umbrella to help all patients, whether they have financial burden or not. Of course, focusing more on patients who are underserved, but in the meantime, understand that these barriers are multifaceted. So we really have to have a very good group put together, healthcare workers, policymakers, and patients advocates as well, to kind of figure out how to grant patients access, how to keep them on clinical trials and maintain them, even if that's what it takes, to provide them with financial support, to provide them with different policies, to allow us, among those clinical trial budget, to budget for patients, for transportation for all of them, instead of trying to pick and choose and then having some hurdles with the IRB in terms of selecting patients and all of that. So these are all very critical points for us in clinic, and I'm glad we're having this session today where we can share this with you. And last slide here, just tapping into how a multidisciplinary approach in large centers can improve patients' outcome. And this is a homegrown, came from the VA here, and thousands of patients here were analyzed, and they looked at different disease settings, and 50,000 patients here were analyzed, and 65% of them received care at those large centers with multidisciplinary approach. And of course, as predicted, 5-year survival was much better, much higher in those patients who, so if this is what it takes, and maybe a healthcare bill to look into extra support, not extra support, but the right word I'm looking forward to is how to reward, large centers to receive those patients and to look for them and help them out, because the outcome is much better for diseases like liver cancer at the large centers. And there are ways of doing that without discriminating against small institutions and small primary care settings. So this is also another very important point, how to reward big centers to take care of those patients, and how to enable them to have the required infrastructure support to enable them to take care of more patients. So this is it. We talked about how we can integrate, innovative therapies to improve patients' outcome, and towards that goal, we really need teamwork and new policies to financially support our patients and their families and help grant them access to new therapies and trials. Also talking about supporting efforts to removing the roadblocks in this area to increase the cure rate in liver cancer. I talked briefly about immunotherapy before surgery as a perfect example to achieve that. And then also, this is very, very important, data sharing and policies towards unified electronic medical records. This is very, very critical, and this is actually going to also help us lower the financial burden on the healthcare system and shift it. If I see a patient at MD Anderson who just had a scan in Dallas 2 weeks ago, I cannot even have an access to the actual images, so I have to get my own scans here. So this is another $8,000 spent within 2 weeks on top of what the patient spent in Dallas. So unified electronic medical records, I know there has been a lot of talks about this for years and years, but it's time to look into these things. And if COVID taught us anything, is just to push forward the telehealth has been in our minds and hearts for years and years, and it happened overnight during COVID. So I'm a strong believer that we can really reach this goal of unified electronic medical records Finally here, we talked about screening patients and importance of early detection and designing trial approaches based on disease etiology and developing some underlying liver disease reserve tools. So all of this just goes back to the same issue of granting patients access, unified medical records, and how to work together towards healthcare policies to encourage and enable our patients to participate in trials and also reward large centers to take care of those patients. Thank you very much.
Okay, perfect. So trying to figure out the thing here. My talk, as Dr. Zerani mentioned earlier, is going to be trying to weave through some of these concepts that have been already discussed by the other speakers. We've talked about what are the gaps in HCC detection and treatment, but how can we address some of these at the community level? So that's going to be my goal here today. So here are my disclosures. They're not related to this talk. So just an overview, we'll be summarizing current gaps in HCC early detection, diagnosis, and treatment at the community level in Texas. And I'm going to be trying to highlight some of the specific barriers to screening and guideline concordant care, as you've heard mentioned by the other speakers. These can occur at the patient, provider, and system levels, so we'll be discussing that. And also, what are some solutions or some interventions to eliminate the disparities we see here in Texas with our patients? So you've heard earlier that HCC is a highly fatal cancer. Dr. El-Serag, mentioned this, as well as Singal, that, 5-year relative survival is only 20%, and it's even lower in Texas, with just 15% of Texans surviving over 5 years when they have HCC. And this really translates, I think this is quite a staggering figure, into just 16 years of loss of life for each liver cancer that we see in Texas. So I think this is really quite sobering. Unfortunately, we detect most HCC, as you've heard throughout the previous talks, at a later stage. The whole goal of early detection, as we mentioned, is to detect HCC at an early stage when curative treatments such as surgery, liver transplantation are still available. However, over 50% of cases are diagnosed at later stages. And you can see here at the bar graph on the right that the 5-year survival just drops off to 12%, 3%, really becomes quite dismal. So this is really the critical piece of how we can improve HCC mortality is early detection. Now, you've heard from Dr. Thrift and others that the burden of HCC is not equally distributed in the United States, both with incidence, but also with stage at diagnosis and mortality. And here are just some examples that I think are pretty striking figures that show that it's not just racial and ethnic disparities or gender disparities, which we hear a lot about, but also socioeconomic disparities and even rural and urban disparities. So for example, Black and Hispanic patients 20% less likely to be diagnosed at an early stage compared to whites. We've shown that in our hospitals in Dallas. But also, advanced stage tumors are more likely among those who are uninsured or underinsured across all racial and ethnic groups. And rural patients are 10% more likely to have advanced stage HCC compared to those that live in urban areas like Dallas or Houston. So this kind of is setting up to show you that the burden is not equally distributed throughout the population. So even when we detect HCC at any stage, treatment delays are quite common. So you see here, this is data from the National Cancer Database. The red line is showing the proportion of patients that receive no treatment over the 2010s period. And you can see that, over 1 in 4 patients with HCC in the United States receive no treatment at all. And the blue line is showing you patients that did receive treatment, but it was delayed. And you can see that 1 in 5 patients experience treatment delays of over 3 months once they have HCC. This is early stage patients, late stage patients, all comers. And as you might imagine, the disparities continue here. So Black, Hispanic, low SES patients are more likely to be untreated. They're more likely to be in that red line. And among those who are untreated, they're more likely to have the delays that are over 3 months, which you can imagine that might result in stage migration. Patient may no longer be eligible for curative therapies, et cetera. So what are some of the reasons for delays in HCC care? Well, we really tried to break this down. This was a study we did at our center where we looked at what are the reasons. Why are patients having delayed diagnosis of over 3 months, and why are they having delayed treatment? And it's a little small here, I don't want you to read each part, but the blue, orange, and green bars represent patient, provider, and system level factors. So just some examples of a provider level factor that might impact disparities would be maybe simply, as Dr. Singhal said, maybe simply the provider doesn't order the test in a timely fashion that's needed or order the guideline concordant treatment. Perhaps the patient might miss the appointment, have issues with transportation, et cetera. There's also system level issues in terms of scheduling and other barriers. And so all of this to say that I think we focus a lot on patient level barriers. You know, the patient didn't schedule the test, the patient didn't have transportation. But we have to think of this in terms of the broader picture that social determinants of health are really what drive cancer health disparities at the end of the day. Even as Dr. Turner pointed out, these aren't just individual behaviors. We can't focus on that. Even individual behaviors are really kind of are impacted by these social determinants of health, which are the conditions in which an individual, you know, is born, lives, works, studies, et cetera. And you see all of those domains here. Further, these social determinants of health are influenced even further upstream by health policy and other structural factors. So, you know, this is a common, I think this is a more new kind of figure that you might see in the literature currently, but where you have these very, very upstream factors that have been present in the United States for a long time. We have structural inequities. We have racism, discrimination, sexism, et cetera, that have led to policies that impact patients' everyday social determinants of health. And these lead to the far, far downstream disparate health outcomes that I showed you earlier. So this is quite complicated, as you can see. And what I like about this figure is it shows you that access to health care is just one piece of the puzzle. It's an important piece, but it's not the entire thing. So I'm going to focus on access a little bit here in Texas for the next few slides, just to give you an idea, and then we'll come back around to the other factors. So there's nearly 30 million Texans, and over 3 million of them are classified as living in rural areas. So this is not a small number of people. We have a lot of counties in Texas. I thought these were some really striking figures showing that many Texans have limited access to health care as well as subspecialists. So 71 counties in Texas have no hospital. 11 counties have no EMS station at all. And then we have only 4 NCI designated cancer centers in the larger cities. So you can imagine that if you live in West Texas, South Texas, you might really have a difficult time with not just transportation, but even being connected with a PCP or a subspecialist in the first place. And in fact, Texas leads the US in rural hospital closures since 2005. You also see the darker states here are the higher proportion of patients who are uninsured. 17% of Texans are uninsured. So you can see we're kind of leading the way in the wrong area in both regards. There's also an increasing shortage of primary care physicians in Texas, which is a huge problem. And we've heard a lot about this during the COVID pandemic, I think nationally. This figure just really struck me, just going from 2019 to 2021, pre and post-COVID. The darker areas are where the whole county is in a shortage area of PCPs, meaning that less than 1 PCP for 3,500 residents. And look at how much of Texas has become dark blue just in the period of 2 years, with very few counties not being in a shortage area. And this is really, as several other speakers have mentioned, most patients with cirrhosis are cared for by PCPs. They're our partners, and so this is a huge issue. They're not all going to be seeing hepatologists like ourselves. So all of this translates into this geographic variation that we see in HCC mortality in Texas. You've seen several of the maps where South Texas, the darker areas, have higher incidence, but also the mortality is worse in these areas as well. So when we think about how can we begin to conquer this, I think, Amit alluded to the cancer care continuum, where we need to look at all along from risk assessment, risk reduction, as Samit mentioned, to early detection, diagnosis, treatment, and finally survivorship. We heard from Amit that early detection, we're really bad at utilization of HCC surveillance. Less than 1 in 4 patients who are at risk, these are patients with cirrhosis, are receiving guideline concordant HCC screening. And he mentioned that there's these various vulnerable points in the HCC screening cascade. It becomes really complex. And I think that this figure really ties in what all of the speakers were talking about. I showed you the access in Texas up there in the red, identifying the patient as having cirrhosis or liver disease, as Samit mentioned. But even if you've identified the patient, there's still several steps where things could go awry. What's very interesting is, of course, the failure to recognize cirrhosis is a huge barrier. This is even worse in people with NAFLD, which is kind of the issue where, when you have a positive hepatitis C test, much easier to think, this patient might have cirrhosis. But these patients with diabetes, it may not be recognized by PCPs or even gastroenterologists. So this was a study from the VA showing that 25% of patients who were diagnosed with HCC had unrecognized cirrhosis at time of their diagnosis. And those patients were 6 times more likely to have advanced stage HCC when they were diagnosed. Amit talked about, that screening failures can occur anywhere. Obviously, the provider ordering the surveillance test is a huge issue. And this was a study that we did at Parkland. And the interesting thing was when the surveillance test was actually ordered, less than 5% of patients failed to complete it. So we put in the orders, we try to reduce the barriers. That's not saying there's not patient-level barriers, but that's a huge part, is just us putting in the orders as physicians. So clearly, there's ways that we can try to make this easier on both PCPs and hepatologists, and even just using risk stratification tools through the EMR. We talked a little bit about how provider and patient education is key to tell the patient, why is surveillance important. And we'll go over in my last few slides a couple of interventions that have been done in this regard. But I think it really takes community engagement, health campaigns, patient education, as was mentioned earlier, to have the patient understand why surveillance is important. The posters in the clinic, I think, is a key intervention. Finally, when we detect a nodule on ultrasound, we need to have a strong recall system in place. So we need to have a way to contact that patient, have the patient come for follow-up testing and not get lost. I think one of the things that also, maybe wasn't pointed out earlier is that HCC surveillance, Amit likened it to getting, mammography or other cancer screenings. HCC screening has to happen every 6 months. So this is a cascade that the patient has to complete repeatedly, making it even more challenging. So one of the projects that was led by Amit, but also with Ruben Hernandez here at the Houston VA, was this mailed outreach study where essentially a one-page letter in either English or Spanish, low literacy level, was mailed to patients at these 3 centers, inviting them to complete HCC screening. And you can see that this really worked. The rates are still low. We still have some room to go, but it increased surveillance from 21% up to 35% completion rate. And you can see there on the right that some of the groups that benefited the most from this intervention are these difficult to reach groups. These were people at safety net hospitals. These were racial and ethnic minorities. As Sumit mentioned, we really need multi-level and multidisciplinary interventions to be able to improve screening rates. These are just a couple examples that have been published, but it shows us that we can be innovative in how we think about designing interventions. It doesn't need to include an MD. So nurse-led clinics have actually had a lot of success. In the Kaiser system, there's been pharmacist-led teams where they identified patients in the EMR and pharmacists called the patients, scheduled their ultrasound. So it doesn't need to include, hepatologists, we can't see all the patients as we mentioned. So I'll just leave you here at the end with talking about some gaps in treatment and how we might address those. You've heard from several of the folks before me that look at this algorithm. HCC treatment is becoming increasingly complex. This is the updated 2022 guidance that we have on liver cancer staging and treatment. But you can see, you can barely fit it on the slide. It's quite complicated. So we need multidisciplinary care, as Sumit mentioned. You can see all of the subspecialties here that are included. And, I showed you 71 counties in Texas don't even have a hospital. So certainly many hospitals are not going to have all of these providers. We know that multidisciplinary care, it reduces delays in care, it improves guideline concordant care, improves survival. But if the patient doesn't have access to this, it's not going to help them. So one of the interventions that's been done is using telemedicine, similar with Project Echo, to try to do these virtual tumor boards, which I think is really a great area that we need to expand further. This has been being done in the VA and being branched out to other areas. But this can, of course, improve access for the rural patients, minimize the transportation issue and costs. However, I think with telemedicine, we really have to be mindful that telemedicine can widen disparities, and we've seen that during the COVID pandemic. Not everybody has broadband internet or smartphones. And so, sometimes with innovation, by improving care for some, we can worsen it for others. Finally, I'll just leave you with this. Dr. Casa mentioned, we have these immunotherapy regimens, we have chemotherapy or immunotherapy and these local regional treatments, particularly for immunotherapy. We have a lot of clinical trials right now, but again, patients may not have access to any of these drugs, infusion centers, clinical trials. This was a really interesting intervention that was done for rural patients in Iowa, Minnesota, and South Dakota, low cost. They had 26 counties that didn't have access to any tertiary care for cancer. And they used a telehealth-based intervention where they trained rural infusion teams. They coordinated the treatment plans. They directed them how to administer the chemotherapy. And these patients were actually enrolled in clinical trials. And you can see the benefits in the purple box that this led to for the patients, significant cost savings, saving patients time. So I'm just gonna leave you with, we can do these smaller interventions on patient education. We can do community-based interventions, but we really need to address social determinants of health in our community and via policy. I think that there's several areas here that fit in nicely, particularly with NAFLD, where we really need to think on a broader level. It's not just counseling one patient about their nutrition, but rather, ensuring, do we have green spaces, do we have availability of healthy foods for all, and some of that is on the policy level. So in summary, there are persistent, significant disparities in early detection, diagnosis, and treatment of HCC in Texas, even in the year 2022. We know that HCC screening is poorly utilized. We know that many patients are not receiving curative treatment despite being eligible. And we know that this is disproportionately impacting racial ethnic minorities, the uninsured, underinsured, and those in rural Texas, I think is really a place where we need to intervene. These barriers can occur across the care continuum, showing you again there. And we really need multi-level, multidisciplinary interventions urgently to try to improve survival for all of our patients. I think it begins with the recognition of cirrhosis, as others have mentioned, and removing logistical barriers for patient, which may include telemedicine. I think the focus on expanding access, we do just need to be mindful that we're addressing the social determinants of health. Patient navigation is a key component, and targeted interventions for our difficult to reach patient populations. So, thank you.
Thank you very much. So, any questions from the people who've been sitting for a while? Can't you see the trend? I mean, the first session is prevention, big picture, etc. But you get the second session, and I think it's intentionally, once you have the cancer, it is tough, it's expensive, the slides are incomprehensible, and all of those things. But that's by design, and that doesn't mean we neglect this part, but that's really the spectrum. These are the choices. Any comments or questions? Dr. Turner.
Social determinants of health, that's something we're all wrestling with, and I think you really did a great job of highlighting that. So do you think there are any low-hanging fruit here? It seems all pretty high-hanging, but I'm just wondering what you think you might want to start with first to try to really get the ball moving.
Well, we have 4 speakers, so each one uses a fruit or a vegetable.
Maybe I'll start so I can get the lowest hanging. So, that's a great, because all of these seem like such pie in the sky ideas, right? I think one of the things, especially with NAFLD, is that's ripe for intervention on a large scale level would be interventions in childhood, childhood obesity being a huge issue, NAFLD being increasingly common in children, and trying to design an intervention in schools, whether it be with nutrition in schools, exercise in schools, and trying to kind of reach people at an early stage and move forward. There's been the Healthy People campaign. Michelle Obama had a nutritional campaign, having celebrities kind of, I think those are some of the higher level things from a policy standpoint that would help address a lower hanging social determinant of health. But clearly access to care insurance, is key.
Dr. Casson.
Yeah, I totally agree. I think access to care really from childhood can really help us. First of all of my patients in clinic, I wish I had never met them. I don't want to see anyone in clinic, but when I see a patient who's healthy, diagnosed early, these are the patients that we can really make a huge impact with. And those patients are usually insured all their life. They have the vaccination, they have the preventive and screening services and so on. While I see some patients who have never seen a physician up until a month ago and all of that, so you really see the brunt of all of these, barriers to access to healthcare. So it goes back to the same thing we were talking about, big dreams. We need big champions here. We need people who take this, and maybe can start with our state of Texas, who are very equipped. We have the capital here, they're always determined, they always balance the budget, they have these things in mind. So I really think we should take this into our hands. Just like the CPRIT program started, these efforts, we need higher level efforts to make sure that everybody has access to not only standard of care, but also to clinical trials to give them the best outcome possible.
Thank you.
So I'll go back to, I love this adage of an ounce of prevention is worth a pound of cure. And so I really do think when you think of this across the entire spectrum, the prevention side, and really the primary prevention side is the most effective and the cheapest, quote unquote, cheapest implementation that we can do. And so I really do think that the efforts need to start there. To Hashem's point, you've seen that as you go from primary prevention to secondary prevention to treatment, you're impacting a smaller and smaller proportion, and you're increasing the cost exponentially. And so I think you really need to start on the primary prevention side. So I'd reinforce that concept as the first thing. To complement what Nicole said, there's clearly, and rightfully so, a big focus on non-alcoholic fatty liver disease. But I think when we have to think of this, we have to remember that it's not just NAFLD. When we talk about non-viral etiologies, we're also talking about alcohol-associated liver disease. And we've seen that this is already common, and we've seen dramatic increases in this during the COVID pandemic. And so I think that's the other aspect that we need to be very aggressive in terms of, alcohol regulation, alcohol education campaigns, in terms of reducing. So you have, Sumit said this, many of us sort of do have healthy alcohol use intake. And so there is a way to do this in a healthy fashion, but I think that it can't be abstinence for everyone, but I think we need, healthy alcohol and alcohol regulation. So I think we need to think through this. There have been studies, and I think Sumit is probably better to speak to this than I am, in terms of even some of the policies that have come in from a state perspective in terms of regulating alcohol that have been effective in terms of curbing some of the alcohol abuse. So I think these are things that we can consider.
Yours.
No, I think education. I think we need to be more aware first at every single level. And I think we need some kind of sexy tagline, like what's liver? I don't know. So if y'all can think of something cool that, which is marketable package, and you can say it around, people will then think about it, and, it becomes part of your lingo. Oh yeah, what about your liver? But I don't think anybody thinks about the liver. Even in my house, my wife's a cardiologist. They're like, oh, I want to be a cardiologist, not a hepatologist. So I think it's just, we need some kind of,
liver is the new red. I like that.
Yeah,
I like that. I sort of wanted to copy that slide.
And then maybe I'll just ask Dr. Kasab one question. It's, so Nicole brought up Dr. Rich brought up this thing about, virtual tumor boards. And then how would you, MD Anderson is a big name, right? It's a recognized name. How would you promote virtual tumor boards, or have you all done that?
The number one cancer hospital in the world.
Thank you, Hashem. I didn't pay him to say that.
Making cancer history.
There we go.
So we have had these efforts, but unfortunately it was kind of limited to the easy access through our system, so through our cancer network, for example. So we have virtual tumor boards for different cancers, including liver. We're trying now to lift up something through the community, but it goes back to the policy, issues in terms of how to access the databases for those, physicians, and how to start contacting them and getting them on board. And there is nothing, no incentives, right? No reward to doing that. So you do it on top of everything else you're doing. So the virtual tumor board setting would be perfect for patients in the rural areas, because it can provide their physicians with the opportunity to present those cases and get an opinion, because those patients cannot travel. So they present the case, de-identified and everything, and that's back again to the policy, right? Because there is so many hurdles. I can tell you with the virtual tumor board for the liver, it took us 3 years to get it through our IRB and all the red tapes, because guess what? Even just looking at the outcome, we wanted to do the virtual tumor board in Texas in the community settings and compare the outcome before and after, and they said, no, you have to have the consent of every single patient, even at a distance, to be able, even though it's de-identified and everything. So these are things that our policymakers can help us with. It provide us with a mechanism to enable us as physicians to do these kinds of, approaches and trials and collaborations without so many red tapes. And I think Texas, among all states, would be perfect for that.
So Mike,
can I just add one thing about the virtual tumor boards? I think the other thing we have to recognize is that the virtual tumor board is just the first step. It gives you the recommendation for that treatment. But to Nicole's point, I mean, many of these areas don't have hospital systems, don't have the expertise, and so we've done some of these virtual tumor boards for some of the rural areas, and we're like, this patient would be a perfect surgical candidate. And they're like, we don't have anyone who has expertise in terms of delivering that. You don't have access to transplant. You don't have access to some of those treatments. And so I think this is not a low-hanging fruit. This is probably the highest hanging fruit that you can have. But I think that we need to work on sort of having it so there's also that expertise more broadly, if it's not locally, at least regionally, in terms of having surgical expertise, IR expertise, et cetera. So I think this is the other thing, is it's not just about that recommendation. It's about having treatment capacity to give it locally.
I think my low-hanging fruit will be sort of a bridge between the morning session and this session, which is the identification of people with advanced liver disease or cirrhosis.
Mm-hmm.
I think this is the population where early detection and screening and surveillance has a potential for improving things down the line. And I think leveraging the issues that were mentioned in EMRs and et cetera may get us there. So that's my low-hanging fruit. I want to conclude this, and we're going to take a picture, but I'm glad you're asking about this, and it just reminded me of this quote that my fruit is tomato. So knowledge is to know that a tomato is actually a fruit, not a vegetable. And wisdom is not to put it in a fruit salad. And philosophy is ketchup really a smoothie. So now we're going to take a group picture. After the group picture, we're going to go grab lunch. We'll come back for the talk by Dr. Ward. After that, and this is really, we're going to have Dr. Deshpande's talk for the insurers, for the payers' perspective. Then Dr. Conwell, who's probably the wisest person I know in this crowd or any crowd, is going to sum up the meeting, and then we'll do our multi-stake. So let's gather in front. People are aware of their own height, so try to be at the front, and Dr. Thrift, please, at the very back.
Hello, everyone. Real quick, lunch is out in the foyer or lobby area, and it's box lunch, so you just grab something and come back and sit down and eat. Thank you.
of enjoying themselves, so it's what?
You want to give it a couple of minutes?
Hello, everyone. If you can make it back to your seats, and we'll go ahead and get started with Dr. Ward's keynote. Thank you.
Well, hello, everyone. I have the enviable task of interrupting a lot of nice conversations going on all around the room. So apologies for that, but Ariel made it very clear that I needed to get back on track here so we can get this back on time. So I'm Dr. John Ward. I'm the director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health, which is a nonprofit organization started by former CDC directors about 40 years ago that works on a variety of disease elimination programs. And I moved over from my previous position as director of the Division of Viral Hepatitis at CDC to start a global hepatitis elimination program at the task force. I continue to work with my colleagues at CDC as well as the National Cancer Institute, which I also have an appointment with. We can talk a lot about what's going on around the world, and I'm happy to do that at any time. But I thought I would really see what I could bring together to be very relevant to the conversation we're having today about what are some ways that we can advance toward hepatitis C elimination in Texas by various policy options. And so I'll be looking a little bit about hepatitis C transmission and disease, prevention, care, and treatment, the benefits, some strategies to expand access. Hope I can make a very good case for simplification for hepatitis C care and treatment, as well as prevention. It was very exciting to hear from Hashem that you really want to bring together a coalition. I mean, that's what we're all about at our coalition, Global Coalition, as we really seek to foster coalitions at the national and subnational level. And we look forward to working with all of you to see what we can do in our part to help you bring that about. You know, we really have a remarkable opportunity that doesn't come along your way very often in medicine, where you have this major breakthrough in medical science that opens up new possibilities to improve health. And we absolutely have that for hepatitis C virus. You know, as probably most of you know, 3 of our colleagues were awarded the Nobel Prize in Medicine for their scientific contributions leading to the discovery of hepatitis C, which was published by Michael Houghton and his colleagues in 1989. It was for the disease that used to be called non-A, non-B hepatitis. We now had an etiologic agent that led to the development of reliable tests and led to the discovery and of the various replicative pathways that made identifying targets for therapies possible, leading to the cures that we have today. So, you know, as I see it, you know, it's our opportunity to turn a Nobel Prize into a noble cause. You know, how do we really seize on this major scientific breakthrough that led to the first cure of a chronic viral infection in the history of medicine, hepatitis C virus? Now, how do we do the right thing and make that science, translate that science into good health practices? Where we are today about preventing transmission is of this bloodborne virus is, particularly for the United States, is for people who inject drugs. Now, around the world, the most common mode of transmission continues to be unsafe health care, blood transfusions that aren't reliably screened, and the like. Now, that still occurs occasionally in the United States, but the major driver is ACV transmission among people who inject drugs because they're using unsterilized, non-sterile equipment, and they're sharing that among themselves. And hepatitis C virus is very transmissible, much more so than HIV. And as a result, you get very high incidence rates, as you can see here, right after the initiation of drug injection behaviors, with an overall prevalence among drug users globally of about 50%. So that's your highest risk population. Now, what we have before us, as I mentioned, we have the opportunity to test and cure. We have, with 1 or several pills a day, 2 to 3 months of treatment, 90% or more are cured of hepatitis C. These drugs have shown themselves to have an excellent safety profile. And what was once thought to needed therapy to be overseen by multiple clinic visits and the like, experience has shown that that's not the case. There was a landmark a study called the MinMon study last year that showed you could give the whole treatment regimen up front to the patient, not see them again until you went into the completion of therapy. This was in multiple countries, and you got around a 90% cure. So on comparability to looking at them more often, which was more complicated. So you have a very highly effective, safe, and that can be applied in a variety of simplified algorithms. Now, one of the issues these drugs first came out, as most of you know, they were very expensive, over $90,000 per cure. And so as a result, a lot of Medicaid programs put up very onerous restrictions, which we're going to get to in a moment. But those costs have declined dramatically in the United States, which I'll touch on, and also around the world. So from about 2015, where a drug was costing about as I mentioned, over $90,000 per cure, you can now get equally effective treatments in other countries for less than $200, and it's really a remarkable opportunity globally. The WHO, World Health Organization, in part because of the availability of these new curative treatments, has targeted hepatitis C and hepatitis B as elimination of a public health threat, defined as a 90% reduction in transmission, 65% reduction in mortality. Those goals were first put out in 2016, and they approved by the World Health Assembly and then re-voted on and approved just this past May. So we have universal approval that these goals for hepatitis elimination should be achieved. How big of a problem is this globally? We have about 58 million people living with hepatitis C, causes about 300,000 deaths per year, and about 1.5 million new infections a year. This is a problem largest in certain parts of Africa, particularly Egypt, had the highest prevalence. Certain parts of southern Asia, such as Pakistan and Bangladesh, certain parts of India, Eastern Europe also have high rates also. Here in the United States, we estimate that there are about 2.4 million people living with hepatitis C. As was mentioned earlier, we have a real baby boomer phenomenon here that was particularly evident in earlier years, where you really had this faith. If you looked at the epi curve for hepatitis C, you had this faithful curve moving through time, which really led me to believe, well, we really should be targeting them for testing, which led to our birth cohort recommendation for HCV testing that we put out in 2012, as well as continuing to target persons that have risk factors for transmission, such as persons who inject drugs. And we had a lot of merit because before the virus was discovered, blood was not being screened, universal precautions that gradually began to be put in place through the 90s, in part because of the AIDS epidemic, were not in place. And there were a lot of other risks in society over and above the major risk of people who inject drugs. And I also thought it was a great way of destigmatizing screening and treatment. But even today, about only 60% of people with hepatitis C report their awareness of infection on national surveys, such as in Haynes. When you look at in Texas, when you compare the prevalence rates there on the left, you see that it's fairly similar to the country as a large, with maybe a slightly larger prevalence among the baby boomer cohort, equivalent among younger people. This particular analysis did not have any information about Hispanics, which is a racial and ethnic population we're very concerned about here in Texas, as was described earlier. This just shows you the mortality rate. The red stars show you again where the mortality is highest, is in this baby boomer group. And of the racial and ethnic disparities there on the left for American Indian and Alaskan Natives and for blacks. Again, some of the demographic trends that we've already touched on here. As I mentioned, our first move toward a general population screen was targeting these baby boomers because they were the majority of people living with hepatitis C. The studies we did using APRI and FIB4, the serologic algorithms that were discussed previously, we showed that half of those had moderate to severe liver disease already, and many of them were unaware of their infection. So we had a really strong case for making this a national recommendation, and it was adopted by the U.S. Preventive Services Task Force. And it takes a little time, to get these policies routinized, and let alone all the challenges that we've already been hearing about. But we did begin to see some increases in uptake in hepatitis C testing, looking at different data repositories of medical records between 140% to 375% increases in testing. So policy change does translate into practice change, even when you have a very modest budget for health promotion and clinical training and the like. We did, over time, identify implementation strategies that were very important. Electronic prompts, as I've already mentioned. Reflex testing, whereby the HCV antibody positive specimen in a laboratory was automatically tested for HCV RNA without the physician having to order that, or the patient return for a second specimen. Importance of clinical education, care management, limiting cost. Some of the other strategies that we've already touched on. So we really have a pretty robust toolkit, actually, of what works for hepatitis C. But now we have this new problem over the last decade now of a new transmission risk and the growth of the size of this risk population of people who inject drugs, driven in large part by the opioid epidemic and the people who move from oral to injection, of those medications. And we've had almost like a threefold increase in incidence because of that, as you can see there in the line graphs on the right. Hep C treatment does work for people who inject drugs. They have similar, comparable treatment outcomes. Adherence sometimes gets raised as a reason not to treat them, but adherence does not have to be rigorous to get high cure rates, including for people who inject drugs. Then people worry about reinfection, but reinfection is about 4 per 8 per 100 person year, so you have about a 4 to 8% reinfection rate, per year. That's not exorbitantly high, and those studies do not include other ways to limit their exposure, such as making sure they have sterile equipment, et cetera. So there's a lot of good reasons to prevent HCV, as well as to make sure those individuals do not progress to cirrhosis and liver cancer. And there's a lot of good, cost-effectiveness data to back that up. So this is where that curve has changed. We used to have this faithful birth cohort curve moving through time. That's now been joined by this second curve of new cases of hepatitis C among young persons, as you can see here. And now we have a bimodal curve. So let's just talk about, now that we have that sort of epi as context, where are we now in our strategies? As we've learned more in treating hepatitis C, the recommendations and the epidemiology has changed. First, we've moved from a birth cohort recommendation alone to a recommendation to treat all adults, which came out in 2020. That CDC recommendation was joined by the U.S. Preventive Services Task Force recommendation, which should make that a no copay preventive service for people going through primary care. It'll be interesting to hear how well that actually plays out, but it does at least give you a policy and perhaps some financial support for expanding testing so that all adults have access to this screening. The question then is the implementation of that policy. Treatment recommendations have also been simplified, as I've already alluded to, so that many of the requirements for staging, for finding and having patients return to the care setting over the course of their treatment has moved away. And in fact, when you go around the world, it's there's very highly successful programs in many other countries, very much simplify staging ahead of time, with the greatest concern obviously missing cases of cirrhosis that need more attention, or the patients that perhaps are on HIV therapy, and then you have to worry about some drug-drug interactions. But for the most part, this is the regimens can be very simplified, and I think it's a real credit to AASLD and that they've really sought to do that and really been a champion of moving HCV care from the specialist to the primary care setting. There are some great examples of highly effective programs. As was already mentioned, the VA is definitely one of those. Because of this birth cohort phenomenon, Vietnam veterans had a very high rate of hepatitis C. And so certain veteran organizations were very, very concerned about hepatitis C, and that translated into congressional attention and congressional action and great funding for a program. The VA made very good use of that. with developing highly structured programs, which they called HITS, Hepatitis C Intervention Treatment Services, I believe, where they really made sure that they were getting good feedback about what was working, so they could continual quality improvement. They had a great data system, great outreach, and great financial support and negotiation for affordable treatments for the system. And as you can see, they had large reductions in those that were awaiting treatment. And they feel like they've treated they've screened over 85%, and feel like they've treated over 85% of their hepatitis C population. So there's a lot. That's one example. Another example is the Cherokee Nation. Although we should look at some of the programs close to Texas, and Cherokee Nation in eastern Oklahoma came to CDC in collaboration with the University of Oklahoma Medical System, really wanting to put together a program. American Indians have high mortality rates from hepatitis C, and so they developed this program. I like this quote from the chief because I think it emphasizes the key importance of political commitment and to a program. There's an old adage in disease elimination that political commitment is as important as technical proficiency in the success of a disease elimination program, and I think that's what we're really talking about here when we think about policy change. But here on the left, you can see some of their strategies for implementation. Universal screening, which started even before the recommendation came out. Patient navigations, having that testing available throughout their system, making this available. I think pharmacists were treating 25 to 30% of the patients, and continue to do so. And now that they've really had this become a routine part of their health system, have now moved over and tried to do more outreach for people who inject drugs and begin to bring that together with harm reduction, as I'll speak of in a moment. You can see the Care Cascade here. They're particularly concerned about this drop-off between the linkage to care and the starting on treatment. And in talking to Dr. Jorge Mira, who some of you know, who was the director of this program, felt like one critical barrier that has yet to be overcome is that they still have to get the medications from another source, and so you still have this gap between seeing the patient and that patient getting prescriptions, and that's just, and he feels like that would be another sort of practice change that would improve this care cascade. There have been a number of sort of local programs that have started to move toward hepatitis elimination as the cost of treatments have declined. A study several years ago by Dr. Jag Chawal in Harvard estimated that any cure less than $40,000, given the cost of liver transplant and the other costs that were already mentioned earlier, makes Hep C cure cost saving in the U.S. health system. So we're clearly in cost saving territory as a nation. The other novel program that just started right before the pandemic is in Louisiana, where they champion what's called the subscription model, or the so-called Netflix model for hepatitis C treatment, which was really pioneered in Australia, whereby you give the pharmaceutical company, you negotiate one price, and you pay that price for unlimited access to to treatment. So the more you treat, the cheaper per patient it becomes. And it's also a very powerful incentive to test, because you want to test and find those people so you can drive down the cost overall of your program. So they implemented that in Louisiana, along with the other features that you can see there regarding patient and provider education, and they put this in place in their correctional system and for their Medicaid populations. And you can see the line graph of those starting on treatment for hepatitis C. Even during, there were some, there's been some dips, and they have incomplete data in the most recent year. But they saw, the subscription model was, definitely increased the number of people that were being treated in Louisiana among populations that were very marginalized to receive care to begin with. So it's, the program is ongoing. They feel like it's on, the right track. And there's a lot of lessons to be learned from that, as I'll allude to in a moment at the national level. The other part of this, they thought they also had some waivers for the capitation rate so that the cost of treatment and care for hepatitis C was no longer applying against your budget for a Medicaid program. So that was also considered to be another policy incentive that was put in place here. So if Louisiana can do this, certainly Texas can do it. Right? I've been talking to Dr. Risha Irvin from Johns Hopkins, who's helping Louisiana evaluate this program. They feel like this is demonstrating high acceptance rate for testing and treatment in a correctional setting. They feel like for the correctional setting, screening people as they come into that setting and as they leave is really, really, really important. And there was high acceptance among prisoners with this opt-out strategy. You can give a full treatment course on exit. They would like better linkage to a community setting to complete that treatment or to document cure. So they feel like that's another example of a work in progress. And then they would like to move just from long-term incarceration facilities to jails and looking at people on probation and in parole, et cetera, and really making an all-judicial system program. I've already touched on, some of these strategies, but it doesn't hurt to look at them again, just to emphasize that we have a very robust toolkit, and the challenges before us as to how to implement those. Now that I'm working at the global level, I have a better appreciation of what's going on in other countries. I've already mentioned treatment cost that used to be a huge barrier. It's rapidly becoming not one. Not universally yet, but 2/3 of all people living with Hep C now live in a country where the drugs are very affordable. So the current challenge is not so much the cost of treatment, it's the testing. How do you get people to test and how to find those people? So you have to have a policy, the training, the data to show how well you're doing. And then the cost of those diagnostics in many countries now are more expensive than the therapy. The cost of an HCV PCR in the Democratic Republic of Congo is like $180. It's probably more expensive there than here, just because there's only 1 or 2 laboratories that have that kind of equipment. Now, I'm interested to see how the response to COVID-19, with these billions of dollars going out to improve virologic testing for COVID, could be applied now to hepatitis C. But those are some of the barriers that we have to continue to be vigilant on. What we want to look at, for discussion in the afternoon is, how do we, get more people treated? This was a recent analysis from CDC looking at claims data for 2019 and 2020 for 2 million people, just looking to see what percent were prescribed an HCV medication within a year of a documented RNA positive test indicative of virologic positivity, and showing that a very minority of patients were being treated within that period of time. And in the states that had Medicaid restrictions, that minority was even greater. So we need to explore what are the reasons for that. But this is a good surveillance data to help us begin that kind of questioning. One of the areas, though, is Medicaid treatment access restrictions. And Adrian Simmons is here from the National Viral Hepatitis Roundtable, and they, along with their colleagues at Harvard, have been doing a great job of monitoring these restrictions that, as I mentioned, were put in place earlier on because of the concern about the cost of HCV medication. So they were restrictions based on your stage of liver disease, fibrosis, whether you were a specialist or not, whether you were had some reason that they thought threatened your adherence, like alcohol or substance abuse, known as sobriety restrictions. So we're going to, thought it'd be good to get a little bit of an update on that. So here, there are 38 states have no prescriber restrictions. So it looks like Texas is one of those. All the restrictions have been removed based on liver damage, so you don't really have to wait till you have cirrhosis to finally get treated for hepatitis C. So those are some of the positive aspects of changes in policies over time. Sobriety restrictions, again, vary between just downright denial, which are in the dark red, versus the lighter red, which is include Texas, where a provider must address some type of counseling or education to a person prior to their treatment, which doesn't seem to be that onerous, but it's just one additional step that could result in someone not getting the treatment that they need. And we already have good data that substance abuse does not impact treatment outcomes. Prior authorization to prescribe treatment is a major barrier that I hear from prescribers in multiple states, where you have to get approval before that prescription can be filled. And just really with all the busy and all the other competing priorities that we heard about this morning, it's just one more hassle that you're making primary care come through. For me, it's, Hep C treatment, it appears, is not complex. It's the system that you're having to work in to deliver that treatment. And I think this is an example of how you're making that system actually more complex and unnecessarily so. That could be avoided. There are many other restrictions. 27 states require documentation of genotype. We'll get to that in a minute. 15 states require documentation of chronic infections. 20 states require the lab to be collected within a certain time frame. 9 states impose barriers to replacing lost and stolen meds. So, like, if you lose it, too bad. 23 states impose adherence to adherence requirements. And there's restrictions for retreatment, including Texas, that you have to go through extra steps if that patient comes back, either because they failed treatment or they have been reinfected. So this summarizes the Medicaid criteria for treatment in Texas. Permissive, no fibrosis restrictions. You can be a primary care provider to prescribe, which is good. Managed care organizations cannot apply extra restrictions over fee-for-service within Medicaid. The restrictions, prior authorization is required for all treatment, which is, I think, a major barrier. The other one that I really found, frankly, surprising is the continued documentation of genotype. We have pan-genotypic regimens. This is not recommended by any liver organizations, AASLD, et cetera. So that increases cost and is another barrier to care. There are limitations about laboratory testing and when it occurred, and the other ones listed there. So there's a pretty onerous list of restrictions for a treatment that's only 2 to 3 months. Studies show you can give all of it right up front, 90% cure, very few drug-drug interactions, and very, very safe. And of course, I think about other countries, and this just shows you an example. We're doing these national hepatitis elimination profiles that's available up on our website at globalhep.org, just to show you that many other countries have greatly simplified, their treatment. And these are just the ones that sort of just pulled a sample from Europe, Asia, the Americas, to show you that other countries are proceeding on with simplifying hepatitis C care, and it's certainly time for us to do that completely for our patients here in Texas and the U.S. But we can't forget, the sort of the community-based prevention that needs to happen for us to cut off that channel of new infections and protect people who are at risk, in our case, people who inject drugs. And you have to do that not only with test and treat, but you have to make available sterile injection equipment through what's called syringe service programs. It's recommended that every person who injects drugs should have about access to about 200 exchanges per year to really be protective, optimally up as many as 300. And here in the U.S., it's only about 30 per people who inject drugs because of the relative paucity of these syringe service programs around the country. And drug treatment programs are also under resources, and so and there's a long waiting list oftentimes for people to get in drug treatment. And then for us, that testing for hepatitis C in those settings is not done reliably, even though it's the highest risk population in the country. So there's a lot of service strengthening that is needed for harm reduction and preventing transmission of hepatitis C. We did this study a number of years ago now, and we did an overlay. The red dots show where new cases of hepatitis C were being reported in the country. The black triangles were showing where was there a syringe exchange program, and just show you the non-alignment of the risk populations with where these prevention services were being applied. And you have to admit that we need more black triangles all over the country, but this illustrated the point very, very well. And then we estimated that we would need another 2,200 programs to have these conveniently available to match this growing population of people at risk for hepatitis C. And I gave you some other data there to show you the lack of delivery of hepatitis C testing in primary care and in these drug treatment settings I've already mentioned. The other population that we're concerned about are pregnant women. There's about 6 to 12% risk of transmission from mother to child, so not as large as for hepatitis B or even for HIV, but still one that we need to be reflective of. Kentucky, which has rivals West Virginia in having the highest incidence of hepatitis C in the country, have very high rates of hepatitis C among pregnant women. They're still the only state that requires pregnant women to be tested for hepatitis C, so that's a credit to their public health system. And then overall, about 1 out of every 300 births in the U.S. Is to a woman who is infected with hepatitis C, translating to about 1,700 children being infected per year in the country. So that's so we just started a registry to get more information about those in collaboration with CDC. So. And also, this is an opportunity to test and treat that mother after delivery now, as there's not a recommendation to treat hep C during pregnancy. So I believe now is the time to eliminate hepatitis C. I've already sort of hopefully made the case for that. So that sort of gives me an opportunity to talk about our newest, most highly visible, credible champion in the United States for hepatitis C elimination in my whole experience of working on hep C, and that's Francis Collins. He's the former director of NIH. He's now President Biden's science advisor. And he called me up in March and says he wanted to put hepatitis C elimination as part of the cancer moonshot for the U.S. And he thought it would be a quick win, to show why you need to have a cancer moonshot. And he was a big believer in that. I think our colleagues, Doug Lowy and others in NCI, was a real help bring Francis up to speed about that. And he stayed true to that vision. And he had a meeting about several weeks ago in August. I think Adrian, perhaps some of you others, listened in on that or were there in the room with Adrian and I to propose this national program, and to find a way of making treatment more affordable, expand testing, and expand access and use of those tests, and then to have that programmatic support that we've been touching on already as far as expansion of drug treatments or in-service programs, clinical training, health promotion in the community, hepatitis surveillance, and other strategic information that we've been touching on. And that's very much what we are all about on our coalition on the right. How do you put together all these key components to make an effective program? So it was really great to hear Francis championing that at the White House level. With Jack Chatwall, we put together what are the benefits of this new program. If we could fully implement it, the little box up there on the top right, just versus the status quo, if we did a better job of full expansion, had a fully comprehensive program, we could avert an additional 70,000 deaths by the end of this decade, and over 340,000 deaths by 2050. By incidence, by including that those prevention services for people who inject drugs, we can avert almost 300,000 new infections by 2030 and 1.2 million new infections by 2050. And we would save about $50 billion in healthcare cost. And about of that $54 billion, say $50 billion of that would come and be saved by the Medicare and Medicaid program. So we thought we made a strong economic argument for the national program. Francis and his colleagues are now seeking to bundle that together to see how that can be put into the president's budget for FY24. So we'll see how that goes. So my take-home points: HCV is a major health problem that can be prevented. I would have to say, when we look at the causes of liver cancer, it's great to see that 70% of liver cancer can be prevented. I would submit that of all those causes, Hep C treatment and cure is the easiest, the lowest hanging fruit of what we're talking about. It's much more easier to cure Hep C than for weight loss, alcohol cessation, and the like. So let's get this done. Prevention programs can prevent 90% of new infections. We got to scale up that at the community level. We have a robust toolkit to make testing and treatment available. We need to begin to apply it and remove barriers, some of which I touched on with Medicaid restrictions as an example. And if we do all this right, we can achieve elimination and have benefits in lives saved and costs saved in our health system, as I will emphasize there. So thank you very much.
I'll just say it here. Wasn't this great or not? I mean, this is amazing. We're waiting for some action. Here's some action. Any questions or comments? While you still have him, he's coming from Atlanta just to do this. Please, Dr. Pond.
I was just curious on what's the current cost for treatment in the U.S. now? You mentioned it used to be $90,000, but it's like $200 in developed countries.
It's very hard. Maybe Adrian may have some. Sort of the recognized cost is about $26,000 for the AbbVie drug. It's often thought that the negotiations between health systems and pharmaceutical companies and pharmaceutical managers, you get less costly drugs. The VA, was my understanding, was more in the high teens.
Yep.
Now, in that Louisiana program where they had that subscription model, they were estimating that based on the number of patients treated per year, which went down during COVID, that they were varying between $3,500 to $7,000 per patient treated. So, Adrian?
Yeah.
Sorry, why is it 20 times more in the U.S.?
Well, that you can say that about many parts of our health system. Rents are higher here. There's a lot of other things that are higher here. So I think, it doesn't necessarily bother me that it's $5,000 versus, $150 in Pakistan. But I think it's for me, it's down to a level where it's fully, it's highly cost saving. You're saving lives. And you look at other things that our system is paying for, this is a very good buy for the patient and the health system.
The only thing that I would add to that is that the $26,000 number is the list price that you would most commonly see, so that's the sticker price of the drug. But most health systems that are participating in the 340B program are purchasing the drug at about $10,000 to $15,000 per treatment course. And then, as Dr. Ward mentioned, that price comes down even further if you have something like a subscription model in place. So the cost has come down dramatically since these drugs came to market in 2014. Everyone referred to it as the $1,000 pill a day, and it was nearly $100,000 per treatment course. So now that we're in the $10,000 to $15,000 range for most health systems, we're certainly in the cost savings arena.
Absolutely.
Fantastic. Other comments? Well, John, you're hanging around, aren't you, for the next hour or so? So don't leave. To stay on time, our next speaker, and the one before the last, is Dr. Salil Deshpande. He is the Chief Medical Officer of United Healthcare Community Plan. He trained at Baylor College of Medicine, followed it by a business degree from Wharton, and a dear friend. So thank you for coming here. Look forward to your talk.
Thanks to Dr. El-Serag and the entire tech team for including me here today. As he mentioned, I am your friendly neighborhood representative from the dark side this afternoon. But in all seriousness, actually have been really profoundly impressed by the fact that, just as an example, that oncologists, that hepatologists recognize the plight of the uninsured, the underinsured, and the challenges that that their social issues bring, and how relevant they are in actually making a dent in what it is that we're trying to do. Over the next 20 minutes or so, I'm going to just share a little bit of insight and thoughts from a healthcare payer's point of view around the continuing opportunities with liver cancer, and in particular, a potential roadmap and some avenues for change as we go forward. So I'm Salil Deshpande. I'm an internal medicine physician. I've been with United Healthcare for about 15 years now. I'm the CMO for our Medicaid health plan, where I've been for almost the past 10 years. We have the privilege of serving a variety of people across the state of Texas, ranging from pregnant moms and their newborns to dually eligible Medicare and Medicaid members, to both children and adults with special health care needs, chronic medical conditions, and in many cases, concurrent coexisting behavioral health challenges that they're facing. And so all of which is to say, we're certainly no stranger to the challenges of liver disease and even to liver cancer among our population that we're helping. So let's move along here. Today, in my brief time with you, I want to really focus on three different things. First, I want to bring to you the payer's perspective on liver cancer. Why is this issue important? What are some of the statistics, risk factors, and economic considerations that make us pay attention to liver cancer? And I'm not necessarily going to be telling you something that you haven't already heard over the course of the day and this morning, but I really want to sort of highlight what it is that jumps out to the payer community. From a payer's perspective, what can healthcare providers be doing to prevent and to screen for liver cancer? Again, from our perspective, what are some of the issues and current opportunities in treatment and clinical practice that we're noticing in the community? What is the role of a managed care organization's disease management program? And what are the opportunities around our relationships with our network providers, again, when it comes to liver cancer? So first we'll talk about these things from a payer's point of view. And then, and especially since I'm coming to this conversation from the angle of a Medicaid payer, we'll speak about a few levers that the state Medicaid agency, and in this case, the Texas Health and Human Services Commission, some of the levers that they can pull to impact and address opportunities as well around liver cancer. And related to these state regulatory levers, I'm going to just briefly summarize Texas Medicaid's upcoming policy changes that some of you may already be aware of, but I just want to point those out as well, specifically pertaining to hepatitis C virus treatment, and which, of course, as we've learned just recently from Dr. Ward, is really one of the most critical levers to pull to mitigate liver cancer. And then third, I want to look at a framework for potential policy change and specific policy recommendations. And for that, I'm going to draw from a national framework, a collaborative of state Medicaid agencies that had been pulled together specifically to focus on hepatitis C. Their findings and their activities are themselves relevant to what we're talking about today, but I think that structure and that framework can also be more broadly adapted to liver cancer as well. All right, so we know that hepatocellular cancer is the most rapidly increasing cancer in the United States. We have talked about the fact that in Texas, the incidence is just amazingly high, about the highest of all of the states in the country. We've got about 3,700 new cases annually here in Texas. 50 or over 50% are due to viral Hep B and C. Eliminating hepatocellular cancer really requires increased access to screening, diagnosis, and early treatment, whether it be for the viral conditions or otherwise. What are some of the economic factors that make us pay attention to liver cancer? So the median direct cost of a patient with liver cancer in the United States is just under $200,000. The estimated cost to the U.S. healthcare system for treating about 40,000 cases a year is, and this was just already more than 5 years ago, was over $4 billion. So again, I said that's the cost of the U.S. healthcare system. This doesn't even include all of the indirect costs that might be related to the patient's to the patient's inability to work, or certainly time taken off by caregivers and so on. Again, much of our data comes from the VA, the largest provider of patients with hepatocellular cancer. And interestingly, what we've learned is that the cost for somebody with cancer is twice as much as that for someone who has cirrhosis, which of course in and of itself is significant, and then a transplant for those people in whom it may be appropriate and indicated can add substantially to that cost, up to $400,000 as well. All right, so what do payers think about the opportunity around prevention of liver cancer? So again, we've talked about how over 50% of all cases are related to Hep B and C, so there's clearly the need to focus on prevention, identification, treatment of those viral infections. We've talked about alcohol, we've talked about NAFLD. NAFLD's prevalence is, perhaps a quarter, perhaps even higher in the state of Texas. It's interesting and maybe even a little scary that NAFLD can lead to cancer even in the absence of cirrhosis. Perhaps that's not the largest majority of the time, but still an issue. Doctors sometimes think of NAFLD as the liver presentation of metabolic syndrome, and again, we've alluded to the fact that in Texas, we're an obese state. We've got a significant proportion of our citizens who are diabetics. So all of this metabolic syndrome closely linked to obesity and activity, likely an opportunity to focus on that, certainly starting right from childhood and into adulthood, the opportunity to increase weight loss, improve obesity, and so forth. Okay, let's move on and talk a little bit about what payers think around guideline recommended screening for liver cancer in particular. Obviously, it's cost effective to identify and treat somebody earlier than later. Certainly there's a higher probability of someone benefiting from curative therapy and hopefully a potentially longer survival. The reality, again, as we've acknowledged throughout the day, that many patients who have undiagnosed hepatitis C, as well as those people who have liver disease or even cirrhosis, these are patients who are being followed, well, hopefully being followed by primary care providers. So certainly a tremendous opportunity to focus on primary care in that opportunity to screen. There have been a couple of studies that have shown some things that I think are quite disappointing. First of all, 40%, up to 40% of PCPs are not familiar with liver cancer screening guidelines. So that's disappointing right there. Up to 30% of PCPs don't think it's in their wheelhouse to be worried about this. That's even more concerning. And certainly that raises, these collectively raise very specific opportunities here. The takeaway is that there is an opportunity, and perhaps as early as at the point of medical education, to really educate providers about correct screening modalities, potentially how to take advantage of electronic health records, to have reminders to do so, to employ outreach coordinators if that's available to them in their practices, what have you. All right. With respect to treatment, what are some of the concerns that a payer has with regard to current treatment of hepatocellular cancer? So we've touched on the fact that there are cost-effective systemic therapies, immunotherapy, targeted therapies for liver cancer, and certainly for a reasonably smaller but a specific population, liver transplant is also a realistic treatment option. But with all of that said, and really observing this from the bird's eye view of a healthcare payer, we see that there are still a lot of uncertainties in clinical practice, which frankly result in deviations from care from one patient to the next in terms of how their liver cancer is treated. And we've also talked a little bit over the course of the day around some of the reasons for that, and again, ranging from ranging from access to care, access to specialists, other access to transportation, for example. But really just to hone in on the reality that, again, liver cancer is, for the most part, usually diagnosed late. And so curative therapies, even though they exist, may not necessarily be appropriate by the time that someone has been diagnosed. And in some cases, some people are diagnosed so late that curative therapy may not be an option at all. Obviously, one of the other things that we see are variations in deciding if a patient is an appropriate candidate for systemic therapies. And another variation that we often see is that when it is identified that they are appropriate candidates, at what point during their treatment course do they receive some systemic therapy? We see sometimes that people will receive locoregional treatment first. Sometimes it happens somewhere in the middle of their course of therapy. So there is that type of variation as well. And I think just to be very clear, while we're fortunate that a lot of these systemic therapies exist and have made significant headway, I guess, in the treatment of liver cancer, the reality, again, is that that there are multiple factors in how they are actually used. Everything from the efficacy of a given regimen to the cost of the drugs to a patient's, personal preference or what have you. So again, from the bird's eye view of a healthcare payer, I want to talk about 3 other opportunities that are, again, relevant to current clinical practice. The first one is really not something that we've talked about at all today, and I'll just touch on it briefly. It's with respect to hospice care. The second is with respect to patient adherence with their medications. Again, we've touched on it a little bit, but I do want to hone in just a bit more around the opportunity there. And the third pertains to the opportunity with biosimilars. So firstly, with regard to hospice. So there was one study that included over 8,000 Medicare patients with liver cancer. And of those 8,000, only about 15% actually received treatment with either chemo or an immunotherapy or radiation. And 50% received no treatment at all. And the interesting thing here for this study was that over 60% actually did receive hospice care. And most interestingly to me, the people who were on hospice actually had a median survival that was slightly longer by 1 month, admittedly not long, but there was a 1 month longer survival relative to what was otherwise an 8-month survival. And more importantly, well, no, I should not say more importantly, there were a couple of other findings in addition to that longer survival. There were also fewer ED visits and hospitalizations and improved quality of life by patient report. And so I'm highlighting this today just so that we can consider the role of palliative care and hospice care in liver cancer, and particularly for its ability to potentially improve survival and quality of life as well. Okay, so the second item I wanted to highlight here is around patient adherence with oral regimens. For patients staying on track with, a patient who has multiple chronic conditions, staying on track with their medications is a challenge at the best of times. And now all of a sudden you've added a new diagnosis of liver cancer, so that's stressful in and of itself. There's a whole bunch of new providers that they have to see. There's a bunch of new medications that they have to take. It's easy to get off track with the medications. And so, there are obviously multiple barriers to a person or to a patient continuing to take their medications. Everything from patient understanding to drug cost to medication side effects to just being able to get to a pharmacy to pick up their drugs. All of these things are relevant. And so, we've got studies in this liver cancer space showing among both commercial, Medicare, and VA patients that the non-adherence rate is in the 30% range. So, obviously with a diagnosis of cancer, a 30% adherence rate does call into question whether the regimen itself is going to be efficacious. And so, we do need to be thinking about that and what we might do to address that. And then the last thing that I wanted to say just for a moment here is with respect to biosimilar drugs. So, obviously one way to think about biosimilars is that they are like the generic version of our immunotherapies and targeted therapies and so forth. And not to belabor the point, but advances in care, as spectacular as they are, don't mean anything if we can't afford them. Okay, and so, the patient and the system has to be able to afford them. And so biosimilars can really significantly impact access to care. And frankly, improve cost effectiveness of the overall regimen. And so we definitely want to be thinking about leveraging them where it may be appropriate. And we also the payers need to have very clear medical policies that really talk through the coverage criteria for those, and so that providers know what to expect when they submit a bill. All right, so let's talk briefly about the role of the health plan and disease management that health plans offer. For a health plan, each of our members comes to us with, complex medical conditions and even more complicated lives. We recognize that each member is unique, and we have a system of care management, a team of disease managers and care coordinator nurses who are experienced in identifying and addressing each of these unique circumstances. And it's routine for us to use our claims data, our lab data, our pharmacy data, and other information, not only to identify at-risk populations, but then also to then connect with those targeted populations that we've identified, educate them on how to optimize their health. That might be everything from educating them about their disease process to educating them about their medications or how to manage or mitigate side effects, or how to how to access food or transportation or pay a utility payment so that they can then focus on their clinical condition. The disease management teams at health plans typically provide telephonic support, but can also provide face-to-face support in patients' homes. And really through this process of regular contact with patients and also through connecting the patients with other resources. It might be a home healthcare nurse, or it might be with tools and technology like digital apps. All of these types of supports and wraparound services are things that health plans can do to support patients. There are a couple of critical functions that managed care organizations have. Certainly one, and when it comes to providers. And one of them, I would argue, is really making sure that our members have access to the quality network providers that they may need, as well as to other community resources. And then the other thing that is really an important function for a health plan is for us to be, I alluded to just a moment ago, all of that data that we have access to, that claims data, the lab data, the pharmacy data. Well, that's also something that we want to be able to share with our network providers as well, so that they can optimize their patients' health. There's certainly an opportunity for us to provide basic provider education. Again, we talked about a moment ago how physicians don't necessarily even feel that it's their place to screen for liver cancer. So there's an opportunity for us to provide some basic education around that. But then there are other very more specific things that we can do. We can provide detailed lists of patients to our panel of primary care physicians to let them know which of their patients actually are at risk for liver cancer based on diagnoses or lab tests or other information that we may have access to that they may not be seeing. And so in addition to offering this basic education, more specific patient information, there really is a very specific place for us to engage our physicians through value-based contracting. And again, I think this has been touched on a couple of times over the course of the day, but it's really important for us to recognize that, for example, we can reward oncologists based on quality measures that are designed to improve outcomes and also to reduce costs in the setting of liver cancer. Some of the measures that we might be tracking over time might include things like surveillance rates for people at risk of liver cancer. It might include things like clinical pathway compliance. It might include things like reduced ED visits and hospitalizations, med adherence, patient status, patient satisfaction. These are all the types of things that they might be looking at. Other options for value-based care delivery could include, and again, these are things that we've talked about over the course of the day. It might include things like encouraging the use of a center of excellence for liver cancer, or using a specialized provider network, or encouraging the use of a multidisciplinary tumor board to collectively agree on a treatment approach. All of these things are potential opportunities for us to incentivize healthcare providers in this space. All right, so we've walked together through a payer's perspective on those considerations that make us pay attention to liver cancer. We've talked about what we should be doing to prevent and screen for liver cancer, our thoughts about opportunities in current clinical practice, and also noted some of the opportunities for health plans vis-a-vis disease management and our providers, and especially value-based contracting. So let's turn our attention now briefly to expectations and guidance that our legislators and regulators might offer or even require in the setting of liver cancer. So one of the first things that I can tell you, at least just based on Texas Medicaid, is that they could choose to designate people with liver disease or people with hepatitis or people with liver cancer as a member with special healthcare needs. And the reason that's important is that then triggers the payer to pay extra special attention to such designated members. And really it triggers an automatic increase in scrutiny and disease management and some other activities. And speaking of disease management, the government can require tailored disease management for people with these diagnoses. And that then triggers other linkages to appropriate medical care and things of that sort. Now, the state Medicaid regulator might require health plans to coordinate with other state agencies, like the State Department of Health Services here in Texas. So there's that sort of linkage to public health that we could also bring to play. The state Medicaid regulator could require us, they could develop quality-based outcomes measures and then track those for each of the individual managed care organizations and then report those publicly. And I can promise you when that starts happening, the entire system begins to start paying attention a little bit more. On a related note, the state Medicaid regulator could take advantage of an existing pay for quality infrastructure and align it. So not to go too far into the weeds, but the state Medicaid regulator pays managed care organizations for how we perform on a variety of healthcare quality measures in different clinical areas, and it's a substantial amount of money. It can be up to 3 to 5% of the total amount of money that they pay us annually to manage the members that we do that's essentially at risk based on our quality performance. And so, again, theoretically, potentially hepatitis C or hepatocellular cancer could become one of the conditions that is measured and that becomes part of that program. And then finally, and one of the things that we've talked about or touched on today is the fact that the government can do something to address the cost of treatment. Developing innovative payment arrangements with the pharmaceutical manufacturers, but also they could step in and address how prior authorization requirements could be streamlined and so forth. So speaking of that, I know Dr. Ward talked a little bit about what Texas Medicaid's requirements are today. I am sort of excited, not 100% excited, but sort of excited to tell you about some upcoming changes to the state Medicaid's requirements around hepatitis C viral treatment that are slated to go into effect on January 1st. I'll tell you, they were originally slated to go into effect on September 1st of this year. That got delayed because the state did not conclude its negotiation with whichever pharmaceutical company they're negotiating with. But the intent is that they will have one designated direct-acting antiviral that will be on the preferred list. And if the provider chooses to use that particular drug, then no prior authorization will be required. So regardless of the Medivir score, regardless of the provider, so it doesn't have to be a hepatologist, it can be a primary care doctor, it can be any Medicaid provider can prescribe that. There won't be any drug screening required or any expectation around sobriety. There won't be any additional refill authorization reviews or anything required. Now, all of that is in place or will be in place on January 1st, assuming you're picking that one drug that they have contracted for. So for any of the other direct-acting drugs, presumably some sort of prior authorization process will still apply. We don't know exactly what the guidelines for that will be, but that will be. Yeah, sure. Okay, so the last couple of things here that we want to talk about are around this framework for how we can move forward for policy. And this is really drawn from a federal work group that was convened by the Federal Department of Health and Human Services. They convened an affinity group back in several years back of multiple Medicaid state agencies, and specifically to focus on what they could do around hepatitis C. In addition to HHS's lead role, there were other agencies involved. The CDC, CMS, HRSA, SAMHSA were also involved. And so I just want to talk really quickly about what some of the activities that the state Medicaid agencies were engaged in and how we can actually bring those to bear in our conversation around both hepatitis C, which is what they focused on, but how we can expand that to think about liver cancer. So there were really 5 sets of activities that all of their things could be combined into. The first was really related to using data to inform policy. So states developed data use agreements between the state Medicaid agency, public health agencies, and corrections departments to exchange information about their individual patients. So that was something new, but that was something that they were able to make progress on. They aimed to identify screening and treatment patterns for certain populations, so for populations with HIV, for women, for incarcerated people. They analyzed data to identify high burden areas, and then they tried to figure out, well, here's a high burden area, there are no providers here, let's try to increase provider capacity there. A second activity really had to do with enhancing provider capacity for testing and treatment. Again, they developed educational content. They also used Project Echo and other means of teaching PCPs on what they could do. A third focus really was around people who were incarcerated, as well as those who inject drugs. There were new systems of care developed so that people who were coming out of incarceration could quickly become Medicaid eligible and have access to care that was determined even in advance of their starting out there. And so 2 additional sets of activities really focused specifically around the direct-acting antivirals. One was making them more affordable, and we've heard a little bit about the subscription model. There are other Medicaid payment opportunities as well to consider. And then, like we talked about Texas and some of the dispensations that the state of Texas is making, there were other very specific structural barriers that were also removed. And then lastly, they came up with a whole bunch of resources that we can still tap into, in the spirit of not reinventing the wheel. There are a variety of provider trainings, payer trainings, resources on Medicaid drug pricing, and specifically also some specific hepatitis C related measures that could then be monitored and tracked over a period of time, and again could be used to incentivize providers and payers alike. So really to recap, we first talked about why payers are interested in liver cancer. We have highlighted some potential directions that the state government can take, and I quickly talked about a very specific framework, a national framework that exists, this affinity group that whose resources we might want to certainly take a look at and potentially even emulate. So with that, I will turn it back over to Dr. El-Serag.
Thank you. Now we're going to have our wrap up, and you'll be part of the multi-stake, so hang on. So we're going to have a wrap up by Dr. Kanwal, and following that, we're going to have the multi-stake group. There are surveys distributed around the room. Please fill them, and we're almost there.
Thank you so much. All right, it's been a great morning, early afternoon. It's great to see everyone here. I'm Fasiha Kanwal. My job is an easy one. I have to just put it all together. So nothing that I will say that you haven't heard already. And you'll see your slides getting repeated in my slide set as well. So I took the liberty of just borrowing things without your permission. And also, I will serve as a bridge. I think that's probably the most important part of my job, is to serve as a bridge between what you've heard already to where we really want to go next, which is this roadmap to our final objective to reduce mortality related to HCC in Texas. So as I was thinking about what really could be the main thing that I can leave you with is this number 3. So if we can think about just 3 things, 3 targets for action. We heard a lot. There are lots of gaps, lots of barriers. I wish we could do it all. I wish there would be this very complicated, complex roadmap that we can put together, but really I think it will be difficult, if not impossible. So I am thinking of just 3 action items, 3 calls to action, 3 low-hanging fruits, whatever you want to call it. Just leave with the number 3. And as I was thinking about number 3 and all the symbolism that happened earlier today, I don't know why did I gravitate to number 3. I have 3 kids, and that's the most that I can handle. Maybe that's the reason, but there's more behind it.
So Greek philosophy, they rely on number 3 as a balance. This is a number that reflects wisdom, the past, present, and future. So I think we'll learn what we learned from the past, know where we are, and really apply it to future. Though we can go with number 4. So poor kids. Anyways, so let's think of number 3 as where we want to end today. And these 3 are going to be stops, intermediate destinations, as we look towards the actual destination, which is trying to reduce mortality from HCC in Texas. And I don't have a perfect roadmap to share with you, but I think that's what we will do together. Think of where we are right now. How do we get to these intermediate destinations? That will be our task during the discussion section. And again, nothing that I will say that you haven't heard today already. So I'm just going to recap, leave you with what I think those intermediate stops could be, but really it's open for discussion and conversation, and hopefully we'll come up with something together. I don't have to say it again. Aaron pointed out many people also underscored Texans, they have a high burden of HCC, probably the highest. Also, people who develop HCC in Texas, they live shorter than people with HCC elsewhere. Dr. Rich mentioned that. We also found that there are opportunities, despite the burden that we have, despite the challenges that we have, as Dr. Turner pointed out. I think there are still some opportunities that are important to talk about, and I'm going to mention 3 opportunities. One is that these risk factors, these high priority areas for risk reduction, Aaron Thrift talked about it, and at least some of them are under our control to some degree. And that I think of that as an opportunity, as pointed out by Dr. Ward. So viral hepatitis, HCV, HBV, overweight, obesity, yes, very difficult to change, but at least we can increase recognition and awareness around that, and alcohol consumption. So these are important targets for risk reduction that I have us come back to. We also talked about this lesion, precursor lesion of cirrhosis. These risk factors that we just highlighted, they all work by causing liver injury, liver inflammation, which lead to cirrhosis or scar tissue in the liver, and that is the underlying precursor lesion for most people who develop HCC. Most everyone with HCC has cirrhosis, and it is potentially identifiable. We heard about it. I think time to use this information and really help us move forward. And the third point that I think I see as an opportunity, we heard it from multiple speakers about the fact that even for people who progress to HCC, it's not end of the road. If we detect it early, there are treatments that are helpful. Early HCC is treatable. Even people with more advanced HCC, there are newer treatment options that are available, but the main thing there is early detection. So with that, this is the framework, the cancer care continuum that Dr. Rich shared with us. The 3 points that I mentioned to you, they align nicely with the first 3 steps in the cancer care continuum. And yes, we have a lot to do, a lot of gaps, a lot of problems that we have to solve, but I would recommend, or I would suggest that we think about these first 3, step A, B, C, as we start on this journey towards reducing cancer mortality in Texas. And with that, again, wrapping up, bringing us to where we heard before, there are 3 risk factors: viral hepatitis, NAFLD/NASH, alcohol-related liver disease, and there's one key high-risk group, people with advanced fibrosis and cirrhosis, that we really could focus on, and these could be the low-hanging fruits for this initiative. I'm going to just quickly talk about each of them. It won't really take a lot of time because we heard about them quite a bit. This is from Dr. Ward. Texas is among the top quarter in terms of prevalence of HCV. We are very big in size, so this percentage can translate into a large number of people. We also heard about that with hepatitis C virus infection that's still untreated. Also, we heard that the goal globally set forward by WHO is to eliminate hepatitis C virus infection-related burden by 2030. This is 2022. You probably all remember where you were 8 years ago. Time flies fast. We have 8 years left running against time. And we really do not have much happening here in Texas in terms of really trying to address this issue. And when we think of elimination, and that's Dr. Ward's area, the goal is global elimination. I completely agree with that. We all agree with that. But really, at least standing here, it's out of my influence. under your influence, but out of my influence. So maybe we focus on things that we can influence, which is the lower levels, maybe regional, state level elimination program, I think even a place where we could influence that to some degree. And if you think of, again, things at micro-elimination level, these are initiatives, interventions that targeted, focused populations. And I think we have a good example for micro-elimination from Dr. Turner's program, and we heard about that, about its success, but also about the challenges that she highlighted really nicely in her presentation, which makes me think that we really need to go to the next level. There are many examples in efficacy, effectiveness, and dissemination programs that we've had, demonstration programs. I think we need to think bigger. We were already talking about it earlier, and really need to move towards statewide programs. And we have a great example. We heard about it from Dr. Ward, or I should say a good example to follow. I'm sure there are many other ways that it could be improved upon. And as we stand right now, we don't really have that in the state of Texas. So for hepatitis C, my first recommendation for call to action is let's think big, at least at the state level. We've done many efficacy studies, we've done many effectiveness studies, there are many demonstration projects. Time for a policy change, time to think big, and I think the first call of action could be this. That the goal for us as this group is to think about what do we do from here till we really make that happen. So that's for Hep C. For NAFLD, again, briefly talk about, highlight the burden that was highlighted by Dr. Aaron Thrift sitting right there, global problem, but really big footprint locally here. It disproportionately affects people in Texas, associated with HCC, but the problems are different. And I think our focus and our vision should also align with that. It's a big problem, many people have it. Finding that small subset that is at high risk is challenging. And I think that's where we need to focus on. That's number one. Second is not many people know that this is a problem. Not many people know where to start screening these 25% of people who are at risk for NAFLD. But I think there is a way forward. This is probably the only new thing that I'll share with you today that you haven't seen already. This is an AGA-NASH clinical care pathway that was published last year. The one good thing about this pathway, it identifies 3 highest risk groups in our communities that could be targeted for initial screening for NAFLD or NASH-related fibrosis. So I think that's probably the first step, necessary step as we implement similar programs, pathways in our populations. Under-recognition was highlighted before. Not many people are aware that this is even a risk factor for liver cancer, and I think that's where we need to start. So for NAFLD, we have a lot of work to do. We have some efficacy studies coming up, but lots of information, lots of data that we still need to collect. But we shouldn't really sit and wait for all of those data to emerge. I think this is the time. It's all bundling it all together because they all jointly affect increased risk. I think the main things we still need to push for, but maybe start at the first step, which is awareness. Make sure people understand it's a common problem and understand that it contributes to HCC. And then at the same time, ask for other real-world evidence. And I think we do need some demonstration studies for NASH and NAFLD also. The last thing is this notion that there is an underlying lesion that puts people at high risk for HCC, which is identifiable, and which is a reason why we also miss people with HCC. Failure to recognize patients with cirrhosis or advanced fibrosis contributes to underdetection, underdiagnosis, and late diagnosis of HCC. And that is very nicely presented by Dr. Fortune, is another opportunity using data, electronic health records that we have access to in most circumstances, to really try to find these people earlier, link them to care, and see if there is something to be done about their HCC surveillance. So I'll just quickly go through that, but that I think is another area may be called to action for us to think about. I'm going to just talk briefly about HCC screening. Amit is not here, otherwise he would probably stop me here. But I do think there is more information that's needed for HCC screening before we really bring it up to where it needs to be. So we continue working actively on generating this evidence. We probably should move towards more demonstration projects, but is it really going to be one of those top 3 low-hanging fruits? I'm not so sure. I'll leave it with you And of course, we will discuss that in the next hour and a half. So this is the 3 potential targets, 3 intermediate destinations, stops, that we can think of in this roadmap as we move towards the final destination, hopefully. Again, challenges are many. We recognize them, but at the same time, as you heard from other speakers, it's time to take action. We cannot keep waiting any longer. So I'll leave you with this, and really looking forward to an engaging conversation, discussion for the next 90 minutes or so we can come up with next steps together. Thank you.
Thank you very much for this fantastic summary. We'll keep the momentum going, and I have good news. It's not an hour and a half, it's only an hour and 10 minutes. We'll get you out of here at 2:30. At this juncture, there are many of you who've been invited and expressed interest in attending the next hour and a half or hour and a quarter of a multi-stakeholder meeting. The rest of you are also invited, but you can feel free to leave if you want to leave at this point in time. There will be no secrets. It will be just discussing the next action plans, but just to declare that. Since some of you might leave, this is time to give gratitude and thank you. Thank you for all of you giving your day and your time on a busy Saturday that you could have been doing something else. Thank you for those who joined us on Zoom. Thank you for people who helped getting us to this point. Thanks especially for the speakers. They've given a lot of time and effort and thought and responded to multiple emails, cutting and splicing and do all of those things. There are certain people without them the meeting would not have happened at all. Ariel Harrison, where is she? Here we go. So on behalf of Tech and Baylor College of Medicine, she's really been the mover and shaker of this meeting, but she had partners, the hosts of this beautiful venue at the Baker Institute, Caitlin May, Laura Hotze, Serena Storm, and Maggie Smith. Those are the people who are up front, again, giving their Saturday, hosting us here, giving us the food, checking us in and out. So thanks to all of you, and those of you who are going to leave, have a great day. I hope no one leaves. And if no one leaves, we're just going to jump into the next one. And Fasiha, since you are on a roll, take us. What do you want us to do? I think the setting is fine. No one needs to change tables or anything. The next, go ahead.
Yeah. Okay. All right. I thought you were going to do it, but it's all right. I'll do it. All right, so this is the fun part. I wish we had longer time for this part, but I see something different on my screen, and I'm hoping this will show up here too for others. But really, this is where I think we put all that we've learned in the past and what we've discussed today to think of where we want to head